Right, hello everyone. My name is Samhar Alouch. I'm a fifth year medical student, and today we are going to go through all the MSI OSPE review content and some of the MCQ and SAQ content. So, without any further ado, let's start. So the way this will go is like this. First, we will start with MSK and then we'll go through dermatology. And the way I will explain is like this, just a sec. So here we have the pictures of the OSPE content of the disease with the explanation of what that finding is. And then a note will pop up and this note will contain the whole explanation of the disease that you need to know for your MCQ, not for your OSPE. So if you are watching for OSPE purposes, just focus on the pictures. If you are watching for like just a general review, focus on the notes too because it contains very high yield information regarding your MCQ and SAQ and your OSPE at the same time. So first we will start with the musculoskeletal system. So here we have a normal bone and normal joint. So here, as you can see in the X-ray, we have the bone, and we have the joints, the cartilage, the meniscus, and everything. Here, the histology of the bone, we have the lamina and the osteoid and everything. And here, for the joint itself, we have the synovial membrane, the cartilage, the subchondral bone. Chondral mean cartilage, so subchondral means under the cartilage. So this is the bone under the cartilage. There is the joint fluid, and this is the synovial membrane. It's important to know the normal like X-ray and histology of the bone itself because you need to know it for the diseases too. So let's start with the bone diseases. And first disease we have is osteoporosis. Okay, so porosis means pores and holes, okay? And these holes are in the osteo, which is bone. So osteoporosis is holes in the bones, okay? So this disease is caused due to loss of the bone, due to high bone resorption, like high osteoclast, or decreased bone formation, which is low osteoblast, causing fragile bones, okay? The growth in osteoporosis is like this. We have pores in the bone itself, as you can see here. And for the X-ray, you can see that there is low bone density. Bone should be more whitish and light in the X-ray. But here we can see that the bone itself is very dark, meaning that it has low density. And for the histological appearance, there is low bone mass. As you can see, compared to the normal, here we have a lot of osteoid. But here we have barely any osteoid. So we have thin trabeculae or spongy bone with wide intertrabecular spaces. So here there is a lot of spaces, should be filled with osteoid, but here it's filled with fat. Okay, so that's osteoporosis. For risk factors for osteoporosis are aging. So when we age, osteoclast increase in activity, osteoblast decreased in activity, and menopause because estrogen protects the bone from osteoclast. So when menopause for women happens, estrogen will be decreased, osteoclast activity will increase, and it will destroy the spongy bone, and we will have like this structure, thin trabeculae with wide intertrabecular spaces. So that's osteoporosis. All I need you to know is pores in the bones, uh, thin and then low density of the bone in X-ray, and thin trabeculae here. Now let's go to the second disease. This disease is very important. I'm not sure if it's covered in your lecture or not, but they will bring it regardless if it's covered or not. In my year, it was covered in BBL. They brought it. Last year, I don't think it was covered. They brought it with two questions in OSPE. So please focus on this disease. We have Paget disease. So what's Paget disease? Normally, if this is the bone, there is bone remodeling. So when bone age, we need to remodel this bone. So osteoclast comes and destroy the old bone, and then osteoblast comes and build a new bone. Okay, so this bone remodeling has a specific speed that causes our bone to be like perfectly shaped. Okay, in Paget disease, there is accelerated bone remodeling. So there is a lot of osteoclast, then a lot of osteoblast, and like remodeling should happen, let's say weekly. But in Paget disease, remodeling happens every day. So it causes the work to be happening way faster than normal, and this leads to abnormal bone formation. Okay? It has four stages. First stage is osteolytic. So we have very high number of osteoclasts that destroying our normal bone. Then we have mixed osteoclast and osteoblastic activity. Then we have osteoblastic, which is high osteoblast activity. And finally, we have quiescent, which is like after finishing this remodeling, we have a formation of new abnormal bone. Okay, it has very abnormal shape and structure. So what are the features of that? In an X-ray of the vertebra, Paget disease will have something called picture frame. So normally the bone should be all dense. Okay, the whole bone should be dense. But in Paget disease, the outer layer is denser than the inner layer. Okay, so we have a thick, shiny outer layer. That's called picture frame. You know the picture when we put it in a frame, the frame is thick. That's in Paget disease. The outer layer, the cortical layer, is way thicker than the inner layer, so it's called picture frame. Then in the histology, we have a very weird high amount of osteoid that's really disorganized. Okay, so if you remember the normal, we have a very regular lamellar bone and osteoid, but here see it's very weirdly structured. That's Paget disease. It's because everything is happening too quickly. Okay? So, the features of Paget disease, if we have someone who has very high bone remodeling, it usually affects the vertebra and the bones of the head. Okay? So, they will have enlarged head because every bone in the head is being remodeled in a very fast way and very abnormal way. They will have headache and it will damage cranial nerve number 8. And when it damages cranial nerve number 8, they will have hearing loss. And when it damages the vertebra, they will have back pain, okay? Fractures, osteoarthritis, and like many problems of the vertebra. As we said, X-ray, they will have picture frame appearance, and in histology, they have their disorganized lamina. I wanted to compare these two pictures because they often come in the OSPE. So this is an X-ray, okay? If we see in this X-ray, the vertebra is like this, okay? This is the vertebra body and this is the spinous process, okay? Spinous process usually not affected in the diseases, so this spinous process, you can ignore it. Okay, but usually I use it for reference to see and compare it to the bone disease itself. So as you can see here, in Paget disease, we have picture frame, okay, cortical thickening with disorganized bone. Also, we can see in Paget disease mixed osteolytic and osteoplastic activity. So as you can see here, some area are sclerosed, but some area are osteolytic. So this happen in Paget disease. So this is Paget disease. If you look to this picture, this is not an X-ray, this is MRI, okay? And in an MRI, the bone appear very whitish, okay? So if you see the spinous process, which is not affected with the disease, it's very whitish. So it's expected that the bone itself here will be whitish, okay? So if we see that the borders here are whitish, that doesn't mean that we have cortical thickening. No, the normal itself is being whitish. So this is not Paget disease. This is not picture frame because normally in MRI the bone is very white and here the bone is also very white. So that's the normal in outside, okay? However, in inside we have very thin and low density. So this is osteoporosis. I want you really to differentiate between these two pictures. In Paget disease and an X-ray, we have cortical thickening with mixed osteoblastic osteolytic activity. So in the picture frame itself, we will have very high, like very white lesion with a very black lesion. It's a mix. However, in osteoporosis, we have low density of the bone, as we can see in this MRI. It's expected for it to be very white like here, but it's not very whitish. Okay, that's that's osteoporosis. Now we have a disease called ostitis fibrosa cystica. So normally, when you have very high parathyroid hormone will activate osteoclast that causes bone resorption. However, if you have a disease that causes a very, very, very high parathyroid hormone, such as chronic kidney disease or parathyroid hyperplasia or vitamin D deficiency, this will cause the osteoclast to be very, very active and causes focal bone resorption. Focus on this focal bone resorption. In osteoporosis, the whole bone will be destroyed and have low density. However, in ostitis fibrosa cystica, PTH will activate a lot of osteoclast that will cause focal bone resorption, like it's in a specific place, okay? So that's ostitis fibrosa cystica. Very high parathyroid hormone that causes osteoclast to be activated and causes focal bone resorption, okay? So after this focal bone resorption happen, collagen will be like put in this place and the remodeling will happen with collagen, not with bone, and we will have something called brown tumor. So if we looked on an X-ray for ostitis fibrosa cystica, we will have a focal bone resorption. It's just in a specific place. If we looked on the histology, we have multinucleated giant cells, which is osteoclast. Osteoclast are multinucleated giant cells. And we will have what we call brown tumor, which is like deposition of a lot of collagen instead of bone. So this is bone, but here it's not bone, it's full of collagen. So that's brown tumor. So that's ostitis fibrosa cystica. Very high parathyroid hormone, very high bone resorption due to high osteoclast. On histology, we have multinucleated giant cells, which is osteoclast. And on X-ray, we have focal bone resorption. Now we'll talk about osteonecrosis. So normally this is the femur bone and we have a lot of blood supply here. However, very few blood vessels or very thin blood vessels reach to the femur neck. So it's a highly necrotic area if there is like obstruction or like destruction of one of these blood vessels, okay? If there is obstruction or destruction or whatever in these small blood vessels, blood will not reach to the femur head, and this will cause osteonecrosis, which is death of the bone. Okay, so as you can see here, this is the normal bone. However, here we have necrotic area. This is necrotic tissue for osteonecrosis. So osteonecrosis, necrosis of the bone due to impaired blood supply. Now, what causes osteonecrosis? Sickle cell disease causes osteonecrosis. Why? Because sickle cell will block this blood vessel, blood will not reach to the femur head, and it will cause osteonecrosis. Also, vascular interruption by a trauma or a hit or whatever. And most importantly, corticosteroid use. Corticosteroid use will cause less blood supply to the femur head and will cause osteonecrosis. It's the most common cause of osteonecrosis. It commonly affects the femoral head, which is the hip joint, like in this picture, and the scaphoid bone. Scaphoid bone also have like low blood supply. Grossly, we will have necrotic tissue. Now we'll talk about Charcot joint. So normally you have your leg, you are like walking or whatever, and you hit the table or you like have a like miss a step, okay? Because you have your neurons, you realize that this happened and you will adapt. You will not damage your leg, okay? However, people who have peripheral neuropathy or diabetes mellitus, they will lose the nerve supply to their leg, okay? And when you lose the nerve supply to your leg, you will not feel like if you are damaging your leg or you are doing a bad move or wherever. So people who have peripheral neuropathy and diabetes mellitus commonly damage their leg, have a missed step, like false step or whatever, and this will cause the joint to be displaced. Okay, so in Charcot joint, Charcot means displaced or subluxated. In Charcot joint, we have disorganization or subluxation or dislocation of the joint itself. So as you can see here, the joint itself is it should be like this, but it's very dislocated and subluxated. And why does that happen? Because we can't feel that we are damaging our joint due to peripheral neuropathy or diabetes mellitus. So that's Charcot joint. Now we have osteomyelitis. So normally the bone itself has bone marrow in the middle, okay? And this bone marrow is supplied by blood vessels and whatever. And then the bone marrow will create like red blood cells, white blood cells, and so on. In osteomyelitis, we have hematogenous spread. So the bacteria affected your hand, let's say, or your body. And it's moved with the blood to reach the bone marrow, and it will cause inflammation of the bone marrow and infection of the bone marrow. So osteomyelitis is infection and inflammation of the bone marrow itself. The route of spread is hematogenous, so it's through blood, and that's very important. After the inflammation happen, like many white blood cells, neutrophils, lymphocytes will come, and it will cause destruction of the bone itself. And after destruction happen, bone remodeling will occur and the new bone will be formed. So one major feature of osteomyelitis is sequestrum, which is dead bone fragment surrounded by new bone. So as you can see here, we have a new bone formation with dead bone, okay? It's in the middle of the bone because it's happening in the bone marrow. So in osteomyelitis, we have a lot of dead bones, which is called sequestrum, surrounded by a lot of new bone formation, okay? And that happen in the middle or the core of the bone, which is the bone marrow. Also in osteomyelitis, because the infection is keep happening, we will have an abscess formation in the bone itself. And this abscess called Brody's abscess. So if you have a bone and suddenly there is an abscess in the middle, that's a Brody's abscess, and that's happening due to osteomyelitis, as you can see here and as you can see here. So as we said, osteomyelitis, infection or inflammation of the bone marrow lead to bone degeneration and the new bone formation. Now, what are the bacteria that causes osteomyelitis? In all cases, the most important one is, or the most common one is Staph aureus. Okay, so if you have a normal patient, it's Staph aureus. If we have a sickle cell patient, it's also Staph aureus. Okay, so Staph aureus is the most common cause of osteomyelitis in all cases, including sickle cell patients. Now, what about Salmonella? Salmonella is a common cause of osteomyelitis in sickle cell patients, but it's not the most common cause. Salmonella normally doesn't cause osteomyelitis, except if the patient has sickle cell, okay? So if you have sickle cell, you are predisposed to have osteomyelitis through salmonella, but that's not the most common cause. The most common cause in all cases is Staph aureus. So if the question asking most common cause of osteomyelitis, even if it's in sickle patient, it's Staph aureus. If the question asked like a patient have sickle cell and which of the following will cause osteomyelitis and Staph aureus is not in the option, then it's salmonella. Okay? If a question asks patient have osteomyelitis and the agent is salmonella, what is the patient suffering from? Then he also have sickle cell disease because salmonella can't cause osteomyelitis except when there is sickle cell disease. We said also the X-ray have sequestrum and Brody's abscess. Now we will talk about joint diseases. So this is the normal joint. I want to focus on left. We have the bone, we have the cartilage, and we have the synovial membrane, and here we have the fluid. However, in osteoarthritis, when the person grows up and like age and become like 60 or 70, we will use our joints a lot, which will tear and destroy our cartilage. Okay, and when the cartilage is destroyed, the bone will hit each other and causes destruction of the bone too, and causes inflammation and everything. And that's osteoarthritis. So, osteoarthritis is progressive degeneration. It doesn't happen so suddenly. It's because we are using the joint every day. So, it's progressive degeneration of the cartilage causing pain and decreased range of motion. What's the etiology? It's wear and tear. So, when we age and when we are obese, we are overusing these joints, destroying the cartilage, and causes osteoarthritis. It is asymmetrical because if I am standing on both legs, that doesn't mean I'm damaging both. Maybe I'm walking more on the right one. Maybe I'm using, I have like a disease or something that caused me to walk more on the left one. So it's the one that's being overused that will have osteoarthritis. So osteoarthritis is asymmetrical because it's related to usage, okay? And usually affect most of the joints, but it's mainly weight-bearing joint, which is hip, knee, and also the hand joints, which is pip, dip. Focus that it affects dip. Dip is the distal interphalangeal joint, so this one, and it's affected in osteoarthritis. Focus on this because it's usually not affected in other diseases. So how does osteoarthritis present clinically? They will have stiffness and pain that worsen during the day. Okay, so when you sleep and wake up, you may have some stiffness and pain, but it will only last less than 30 minutes because osteoarthritis happened because we are using the joints. And I just woke up. So why would it happen? It happens throughout the day and especially at night because خلاص, I use the joint a lot. Okay. Now, what are the special features of osteoarthritis? In the hand, we have two nodules. Okay, because when the bone is destroyed and the new bone is formed, it will be formed in a bad way, so it will cause nodes. And if it's in the dip, okay, the distal one, then it's called hiberdin. As you can see in hiberdin, it has a D, okay, in the middle of it, a D. So it's in the dip hiberdin. However, in the BIP, which is the proximal one, it's B, so it will have the B one, which is Bouchard node. So in osteoarthritis, there is Bouchard and Hiberdin node. Bouchard, because it starts with a B, it will happen in the P, okay, PIP. Hiberdin, because it has a D in the middle of it, then it will happen in DIP, okay? So this is Hiberdin node and this is Bouchard node. As you can see here, these are the nodes. Now, when we look on the X-ray, we will have four signs called suns, okay? Now, when osteoarthritis, I will explain them with the pathophysiology. So when osteoarthritis happen, the cartilage here will be destroyed, okay? And when the cartilage is destroyed, the bone will be obvious, okay? Because it's covered with the cartilage. And when the cartilage is gone, the bone will be obvious and the bone will rub itself, be destroyed, and then a new bone is formed, and the new bone is weak and weird. So we will have subchondral sclerosis. What does subchondral mean? We said subchondral means under the cartilage. Okay, so under the cartilage, the bone will be exposed. So we will have subchondral sclerosis. Like, let me just remove this. Like here, we have in the cartilage line, it's very whitish. Usually it's not that white. But here it's very whitish because we have subchondral sclerosis, which is degeneration of the cartilage and exposing of the bone under it, okay? Then we have osteophyte formation, okay? What's osteophyte? It's a very small bony node that shouldn't be there, but it happens because of the bad bone remodeling, which is here. Then we have joint space narrowing because the cartilage is gone, the bone is hitting each other, so the joint space will be very narrow. And finally, we have something called subchondral cyst, which is like this is the cartilage, and then I destroyed this part. So now the cartilage will have an opening here, and this opening is like a cyst, so it's called subchondral cyst. So as you can see here, so osteoarthritis has four X-ray signs, which is summarized by SUNS. S is subchondral sclerosis because the cartilage is gone, the bone is exposed, we have sclerosis. Then we have O, osteophyte formation, because the bone is destroying each other, a new bone will be formed, which is weird, and it will be an osteophyte formation. Then we have N, which is joint space narrowing, because the bone is now hitting each other, the joint space will be very narrow. And finally, the S, which is subchondral cyst, as we said in the cartilage, when it's destroyed, an opening will be formed, and this opening is like a cyst, so it's subchondral cyst. I hope everything is clear. Now the treatment. For an acute painful episode, we can give NSAIDs or glucocorticoids, but for long term, they need to exercise and lose weight. Now we go to the second disease, which is rheumatoid arthritis. Now, normally this is the joint, this is the bone, this is the cartilage, and here we have the synovial membrane, and synovial membrane have some muscles and like layers in it. Okay. And now in rheumatoid arthritis, it's an autoimmune disease. So it's not because we are using the joint a lot. No, it's just autoimmune. So we have autoimmune antibody that goes and destroy the cartilage. It starts attacking here. Also, the autoimmune antibodies will attack the synovial membrane. The main target is synovial membrane. However, it also attacks the cartilage. Now, when it attacks the synovial membrane, it will destroy it and cause formation of something called pannus. So this is the synovial membrane, and pannus will be formed. Pannus is a collection of immune cells and immune cells and muscles, mainly muscles, okay? And these muscles will cause contraction. And if just imagine with me, just a sec. Just imagine with me that we have a pannus here, and this pannus is full of muscles and it contracts. It will pull these bones with it, and it will cause subluxation of the joint. So the joint is like this, but then it becomes like this, okay? Because the pannus has contracted and pulled the bone with it. So in rheumatoid arthritis, because of all of this, like the pannus formation and then the pulling of the joint and the bones, we will have ulnar deviation of fingers. So my fingers is like this. This is the ulnar side and this is the radial side. My fingers will go like this. This is ulnar deviation. On the other hand, the wrist will go radially. So we'll have ulnar deviation of fingers and radial deviation of wrist. Okay. Also, we have swan neck deformity. So this is my finger, and the rheumatoid arthritis doesn't affect dip. It only affects PIP, which is the proximal one. So it doesn't affect this one, it affects this one. And it will cause subluxation of it. So as you can see here, it becomes like this. So that's swan neck deformity. Hyperextension of dip. Dip is like this flexed, and like this is extended. As you can see here, it's hyperextended. And finally, we have boutonniere deformity, which is having the hand like this. And it's the same as like swan neck deformity. It's due to damage to PIP, but here it's flexion, not extension. So this is PIP. Okay, normally if we have it hyperextended, that's swan neck deformity. If you have it hyperflexed, that's boutonniere deformity. Okay, however, it doesn't affect dip. Now, what are the signs of rheumatoid arthritis on an X-ray? It's like what we explained in the pathophysiology. It's summarized in NESA. Okay. N is joint space narrowing because, as you can see here, if we destroy the cartilage and we have pannus formation and we pull the bones, it will hit each other and we will have joint space narrowing. When the bones hit each other and the inflammatory cells destroy the bone, we will have erosions, as you can see here. Okay, and then S is subluxation and deviation. As we said, the pannus will cause subluxation. And finally, when the two bones are subluxated and hitting each other and the new bone is formed, it will fuse them together and we will have ankylosis, which is fusion of the bone. As you can see here, this is not a joint anymore, it's bone. So it's fusion of the bones. Okay, that's the like articular manifestation of rheumatoid arthritis: ulnar deviation, swan neck deformity, boutonniere deformity, and NESA, which is joint space narrowing, erosions, whatever, and ankylosis. However, it also has systemic manifestation because rheumatoid arthritis is autoimmune disease. It's not related just to the joint itself. It's a systemic disease that affects joints. Now, what other manifestation it will have? The autoimmune disease can go to the skin and causes rheumatoid nodules. These nodules are subcutaneous nodules, like under the skin, and they have central fibrinoid necrosis. Please memorize the pictures. Rheumatoid nodules are subcutaneous nodules, so it's under the skin, and it have central fibrinoid necrosis, like fluid in the middle. Okay? It also have rheumatoid pulmonary nodules, which is in the lungs. بس يعني not that high yield. The pictures are for the cutaneous one. So final time. Rheumatoid arthritis is a systemic autoimmune disease due to antibodies against synovial membrane and the cartilage, but mainly the synovial membrane. The pathophysiology are like this. The autoimmune antibodies are called anti-CCP and rheumatoid factor. The most important one is anti-CCP. Anti-CCP and rheumatoid factor will attack the synovium, cause pannus formation. Clinically, they will have fever, malaise, which is muscle pain and whatever. Joint, they will have arthritis with morning stiffness. Now, I want you to focus with me. In osteoarthritis, it's caused due to overusing of the bone, okay, and the joint. So in the morning, they will have few morning stiffness, which is less than 30 minutes, and it improves with walking. So if I walked and do my activity, it doesn't improve with walking. It worsens with walking. So if I walked and do my activity, it will worsen because it is wear and tear disease. However, in rheumatoid arthritis, when we sleep and wake up, the autoimmune antibody will accumulate in the joint because we didn't move. So the autoimmune antibody will accumulate in the joint, and when we wake up, we will have morning stiffness longer than 30 minutes. It's a very, very long morning stiffness. However, when we walk and do our activity, blood will come and like everything will happen and you will move your leg. And so the autoimmune antibody will be washed out and it will improve with activity. So the pain and everything will be gone. Okay? So in rheumatoid arthritis, they have arthritis with morning stiffness, which is very long, more than 30 minutes. However, it improves within the day. It improves when I walk. It improves when I do my activity. And improves mean the pain is gone. Okay? Now, it is symmetrical because osteoarthritis, it's because we use the joint a lot. So if I'm using my left hand more than my right hand, I will have osteoarthritis in my left hand. Okay? However, in rheumatoid arthritis, it's autoimmune. So autoimmune antibody will go to the joints in both sides. So it's symmetrical. Also, it affects small joints. So it's mainly in the hand. Okay? It usually doesn't affect the leg. So it's mainly in the hand, small joints, wrist, especially wrist and pip. However, it doesn't affect dip. If in the case dip is affected, you exclude rheumatoid arthritis and think of osteoarthritis. So it spares dip. Now, diagnosis-wise, anti-CCP is the most specific. Rheumatoid factor is sensitive. Treatment, we have NSAIDs, glucocorticoids, and long-term treatment is DMARDs. I won't go through that, but you need to go through it alone. Now we have a disease called seronegative spondyloarthritis. So in rheumatoid arthritis, it was rheumatoid factor positive. Okay, so the autoimmune antibody are rheumatoid factor and, as we said, anti-CCP. In seronegative spondyloarthritis, it's seronegative, so it's rheumatoid factor negative. So it's an autoimmune arthritis that's not caused by rheumatoid factor. That's what seronegative mean. Spondylo means it affects the spinal, like the spinal bones, and these things. Arthritis means joints. So seronegative spondyloarthritis is a group of joint disorder characterized by three things. First, it's seronegative, so no rheumatoid factor. Spond means it affects the axial spine or spinal spine, the spinal skeleton. And it is HLA-B27 positive. That's the main thing. HLA-B27 positive. So all seronegative spondyloarthritis, which are three diseases, are HLA-B27 positive. Now we have three diseases: ankylosing spondyloarthritis, psoriatic arthritis, and reactive arthritis. Okay, we will start with with the most important one, which is ankylosing spondyloarthritis. As we said, ankylosing spondyloarthritis is spondyloarthritis, which is affect the spine because it has the word spond, and the sacroiliac joint, and it's HLA-B27 positive and rheumatoid factor negative. In ankylosing mean fusion of the joints. So in ankylosing spondyloarthritis, we have fusion of the joints. So here, if you looked at the vertebra, we have fusion of the vertebra body, or become very close, and they will look like a bamboo spine. So in ankylosing spondyloarthritis, the vertebra will fuse together and they will look like a bamboo. Okay, so it's called bamboo spine. Also, it affects the sacroiliac joint. You need to memorize this thing about ankylosing spondyloarthritis. It affects the sacroiliac joint. So here, the sacroiliac joint is inflamed. As you can see here, it's very white and it's fused. So it affects the sacroiliac joint. So features are fusion of the vertebral body, bamboo spine, sacroiliac joint pain and inflammation. And also it have extra, because it's a systemic disease. Anyway, it's an autoimmune disease, okay? An autoimmune disease causes more than just arthritis. So it will have other stuff such as uveitis and aortitis, and sadly, you need to memorize these things. So ankylosing spondyloarthritis, it affects the vertebra and the aorta, similar to each other. Both of them are very like long and going upward. So it affects the aorta and the vertebra, and it affects the sacroiliac joint and the eye, causing uveitis. Okay, that's ankylosing spondyloarthritis. Most important thing are these two pictures, by the way, and back pain. Now we have psoriatic arthritis. Now, of course, you heard from Derma about psoriasis. Psoriasis is like a skin disease. We will talk about it in Derma. However, it has a manifestation on the skin called psoriatic arthritis. It's autoimmune inflammation in the skin. Okay, it is seronegative spondyloarthritis, so it's rheumatoid factor negative. It's HLA-B27 positive. It affects the axial skeleton. However, it also have a very important feature. When it affects the hand, it will have sausage fingers. Okay, when the autoimmune antibody in psoriatic arthritis affect the hand, it destroys the joints and causes telescoping of the fingers into each other, so it will go inward and causes sausage fingers. Also, when it destroys the joint, it causes this this feature which called pencil in a cup appearance. So this is a pencil and this is a cup, and it has a pencil in a cup appearance. So you need to memorize this about psoriatic arthritis. Finally, we have reactive arthritis. Reactive arthritis is also HLA-B27 positive. It is rheumatoid factor negative. It affects the axial spine. However, the most important three feature about reactive arthritis is this mnemonic: can't see, can't be, and can't climb a tree. Can't see means that reactive arthritis is affecting the eye, causing conjunctivitis. Okay? Can't pee means that you can't like go to the bathroom and pee. And that's because of urethritis and something called panelitis, which is inflammation of the penis head. Finally, it causes arthritis, which is can't climb a tree. Why you can't climb a tree? Because it causes arthritis, especially in the knee joint, and it causes a skin lesion called keratoderma bilirubicum, which is this thing. So reactive arthritis is a seronegative, so it's rheumatoid factor negative, HLA-B27 positive, and it's memorized by the mnemonic can't see, can't be, can't climb a tree. It's a 5 thing. Can't see is conjunctivitis. Can't be is urethritis and palanitis, which is inflammation of the penis head. Can't climb a tree is arthritis of the leg, and keratoderma bilirubicum, which is a skin lesion. By the way, this is important because I saw a question. They just said someone has keratoderma bilirubicum and conjunctivitis. What's the disease? You need to choose reactive arthritis. Now we will continue with other joint diseases. So imagine this is a joint and we have something called uric acid, and uric acid is accumulating in the joint itself. This is gout arthritis. So gout arthritis is caused due to accumulation of uric acid crystal in the joint itself. When uric acid accumulates here in the joint, it will cause neutrophils to be activated and causes inflammation and severe pain. So gout is due to uric acid accumulation, causing arthritis, and severe pain due to neutrophil activation. Okay, most common locations are big toe, ankle, and knee, but the most important one is the big toe and the ankle. Now, clinically, they will have an acute episode due to like neutrophil activation, and they will have severe pain. However, chronically, after this episode of pain is gone, they will have development of tophi or renal stones, because uric acid may accumulate in the kidney and cause stones, or it accumulates in the joint itself without neutrophil activation and causes tophi formation, or what we call podagra. Podagra is the tophi of the big toe itself. Okay, so clinically, gout arthritis have two features: acute episodes, which is severe pain due to neutrophil accumulation and activation, or chronic gout, which cause renal stones or development of tophi. Lab-wise, it has high uric acid. When we take synovial fluid analysis from the joint itself, we will have needle-shaped crystals. So uric acid crystals are needle-shaped with negative pyrepharinges. I won't explain what's pyrepharinges test, but if you see it as yellow, that's negative. Okay? So yellow pyrepharinges test is negative, and if it's needle, that's gout. Okay, so synovial fluid analysis of gout, yellow, which is negative pyrepharinges, and needle-shaped crystal. Treatment-wise, for the acute episode itself, the first line treatment is NSAID. Second line is colchicine, and third line is corticosteroids. However, chronically, we need to reduce the amount of uric acid, so we give allopurinol, which is xanthine oxidase inhibitor. It inhibits the formation of the uric acid itself. So for the acute episode, first line is NSAIDs. That's a very common question. Second line is colchicine. Chronically, we give allopurinol, which decreases the uric acid formation through xanthine. I forgot the name of the enzyme, xanthine oxidase or whatever. So it inhibits that enzyme and prevent uric acid formation. Now we have something called pseudogout. So it's similar to gout, however, it's not gout itself. In gout, we have accumulation of uric acid crystal. However, in pseudogout, we have accumulation of carbon peroxidase pyrophosphate, what's called calcium pyrophosphate crystal. Okay, so in pseudogout we have uric acid. However, in pseudogout we have calcium pyrophosphate. So it's calcium accumulation. Clinically, it's same to gout. It accumulates in the ankle, in the big toe, in the knee, and causes severe pain or whatever. However, in X-ray, in gout, the crystals accumulate in the joint and causes inflammation. However, in pseudogout, it accumulates interarticularly. So it's not on the joint or the bone itself, it's just between the bones. As you can see here, it's between the bones. Okay, so in pseudogout, we have interarticular deposition of calcium pyrophosphate crystal. As you can see here, it's just between the bones, more clearly here. Okay, when we do synovial fluid analysis, we will have rhomboid-shaped crystal. This is rhomboid shape. Okay, so uric acid crystals are needle-shaped. However, in pseudogout, it's rhomboid-shaped. Okay, and it's positive pyrepharinges test, so it looks blue. Okay, so gout is negative, looks yellow. However, pseudogout is positive and it looks blue. Okay, and it's rhomboid shaped. Why does this happen? Due to very high calcium, because it's accumulation of calcium pyrophosphate. So it's gonna be due to very high calcium levels. What causes very high calcium levels? PTH, like hyperparathyroidism, high calcium intake, and any disease that causes hypercalcemia. So, final time, pseudogout is accumulation of calcium pyrophosphate interarticularly, so it's between the joints. It's same as gout clinically, however, in synovial fluid analysis, we will have rhomboid-shaped crystals, and it's positive pyrepharinges test, which is blue. Positive, blue. Negative, yellow. And why does it happen? Due to hypercalcemia. Now, another cause of arthritis is septic arthritis. So this is the joint, and we have someone who had a disease or an infection, and the bacteria will move through blood and affect the joint itself, causing inflammation of the joint. This is septic arthritis. Inflammation of the joints due to infection. Okay? Now, if I have like my hand joints, my leg joints, this is me. Okay? This is my hand joints, and these are my leg joints. Septic arthritis occur in one joint only. Okay? So it's monoarthritis. So if I got an infection and it moved through blood, it will go to one joint only and causes inflammation and causes septic arthritis. So septic arthritis is monoarthritis, one joint only, due to infection, and mostly it's bacteria infection. Most common cause is Staph aureus. Okay? However, in sexually active people, like 20 years old, 25 years old, it's Neisseria gonorrhea, and another cause in Kingella kingae. It's mostly occurred due to hematogenous spread, so it moved through blood. So I get the infection in my hand and move through blood and affects my leg. That's very important question, and it's usually asked. And the most common location is the knee. Okay? Now, clinically, someone will suddenly present with a warm, swollen, painful, very erythematous knee. Okay? Or a joint. But mainly it's the knee. So someone with very warm, swollen, painful joint, one joint only, so sudden, that's mostly septic arthritis. When we do synovial fluid analysis, we will see the bacteria itself, and we will see very high white blood cells. Okay, lab-wise, we will have high SR and also very high white blood cells. Treatment, NSAIDs, and antibiotics. Now, I want you to focus on the bacteria itself. This is Staph aureus, gram-positive cocci in cluster. This is Neisseria gonorrhea, gram-negative that accumulates in the macrophages. And this is Kingilla kingi. Okay, memorize the picture. And that they are the most common cause of septic arthritis is Staph aureus. However, in sexually active people, we choose Neisseria gonorrhea. Now, we also have another cause of septic arthritis that only happen in prosthetic joint. So if I have like hip joint issue and I remove this bone and I put prosthetic joint, this prosthetic joint is made of metal. Some bacteria will go to this metal, put something called biofilm and adhere to this biofilm. Okay, so it's like a glue. And when they adhere to this biofilm, it will cause inflammation. So, septic arthritis may occur in prosthetic joints. It's occurred due to bacteria putting biofilm. What's the bacteria that puts biofilm? It's what's it called? Staph epidermidis. Okay, Staph epidermidis is called coagulase negative bacteria. Coagulase negative because it doesn't have coagulase. That's what differs it from Staph aureus, and it's the one that secretes biofilm. So, three important info here. Septic arthritis can occur in prosthetic joint due to biofilm secretion from a bacteria. This bacteria is coagulase negative, which is Staph epidermidis. Okay? Now we have something called Lyme disease. Now we have a tick called Ixodes tick. This Ixodes tick have a bacteria in it, parasite in it called Borrelia burgdorferi, whatever. Okay? I've never, by the way, memorized the name. I just know Borrelia. So this tick, which is the Ixodes tick, have Borrelia, and when it ticks the person, it causes something called Lyme disease. Lyme disease causes a lesion in the hand or in the arm called erythema migrans. Erythema migrans looks like a bull's eye, like this, okay? And it will also cause arthritis. That's all I want you to know. We have a tick called Ixodes tick. This Ixodes tick have a parasite in it called actually it's not parasite, I think it's bacteria. It was bacteria. It has bacteria called Borrelia. This Borrelia, when it infects the humans, it will cause two things. It causes more, but for the sake of the OSPE, two things. Erythema migrans, which is bull's eye, like this, and arthritis. That's all I want you to know. Now, the treatment for Lyme disease for adults is doxycycline, for children is amoxicillin. You need to memorize this because one time they asked this question. An arthritis that is treated in adults with doxycycline and in children with amoxicillin is what disease? And you need to say like Lyme disease. Okay? So, Lyme disease. Ixodes tick have Borrelia. When it ticks you, it will cause two things. Erythema migrans, which is bullseye, and arthritis. The treatment for adults is doxycycline, for children is amoxicillin. I hope everything clear for the bone and joint diseases. Now we'll go to something more fun, which is sports injury. You just need to memorize the picture and the name. It's not diseases. So first we have anterior and posterior dislocation of the shoulder joint. So this is the shoulder joint, and it may dislocate either anteriorly or posteriorly. I want you to imagine this. Wait. So this is the shoulder joint, and this is the humerus. Okay, this is anterior, this is posterior. So when it's dislocated anteriorly, okay, the upper part will go anteriorly, the down part will go posteriorly. However, when it goes posteriorly, the upper part will go posteriorly and the under part will go anteriorly. When we name the dislocation, we only focus on the upper part. So as you can see here, the bone itself is going anteriorly. Okay, here. This is the anterior because this is the chest of the person, and it's going anteriorly. Okay, now when it goes anteriorly, it may hit the axillary nerve. Okay, or even it go posteriorly, it may hit the axillary nerve. So in shoulder dislocation, the most common nerve injury is axillary nerve. That was a question. So this is anterior dislocation. It moves anteriorly and inferiorly. It goes down and anteriorly. Now, in the posterior dislocation, it goes posteriorly. So as you can see here, it's going backward. And it has a specific sign, which is light bulb sign. Light bulb is like the light itself, you know, when someone had an idea, they have like a light bulb in their head. So yeah, that's the light bulb sign. That's posterior dislocation. This is a very common picture to be asked, by the way. Most common nerve injury in these is axillary nerve. I think I wrote it here, yeah. Now, types of fracture. We have a bone and we fracture it. How can it be fractured? First, we have transverse fracture, which is like horizontal. Then we have linear fracture, which is linear. Then we have oblique fracture, which is goes obliquely, but it's not non-displaced. So the bone is still intact. However, we have oblique but displaced. So the bones are displaced. Then we have spiral fracture. It's oblique, but the bone rotates. So when the this is bone and we fracture it, if it stays the same, that's oblique. If one of them rotates, that's spiral. Then we have green stick, and that's very common in OSPE. Green stick is just fracture on one side. It's like when you have a stick and you do this with them and you fracture them, that's green stick fracture. And finally, we have comminuted, which is like complete destruction of the bone. So first we have transverse fracture. As you can see here, it's horizontal. That's it. Here we have oblique fracture. The bone is fractured. That's all. Here we have spiral fracture. It's an oblique, but look, the bone has rotated. Even here, the bone is not just rotated, it's completely displaced. Here we have something called a avulsion fracture. It's like avulsion means shadiyya in Arabic. It's like when you have a whole thing and you just fracture one part of it and this one part is just thrown away. That's avulsion. Okay, so avulsion fracture is a fracture of a small bone that's displaced. This bone is usually attached to a tendon. Okay, so when it's displaced, it moves with the tendon. So as you can see here, there is a tendon that's attached to this bone, and now when it's fractured, it's moved, it's displaced. Okay, and that's avulsion fracture. Even here, this bone has a tendon attached to it. When it's fractured, it moves, and there is another fracture here. When it moves, it goes like away. Okay, that's avulsion fracture. Now, specifically, this fracture, like this avulsion fracture of the DIP of the index finger, is called mallet finger. It's common in baseball and football goalkeeper. When the ball hits the fingers of the like player, it will fracture this and it will be displaced. By the way, I have this. If you look here, if you compare here, there is nothing, but here there is like an avulsion. So that's avulsion fracture, that's mallet finger. Remember, mallet finger is the avulsion fracture of the index of the dip, like of the dip of the index finger, and Samhar has it. It came twice in the exam. It came in my exam and the like a batch previous to that. All right, now we have longitudinal fracture, which is a fracture that goes longitudinally, like a line, straight line above. And then we have green stick fracture, which is like a fracture that when you have a bone and you do it like this, it's a fracture like a green stick. So that's green stick fracture. Then we have comminuted fracture, which is a complete destruction of the bone. It's like this, horizontal, oblique, spiral, everything. Okay. That's comminuted fracture. And then we have torus or buccal fracture, and this is very important. It's a fracture inside the bone itself that causes pooping of the bone, like this, but it doesn't go throughout the whole bone and fracture it, okay? That's buccal fracture. So buccal fracture is a fracture inside the bone itself, but it doesn't completely destroy the bone, okay? It causes pooping out of the bone, and that's it, okay? There's another picture of like two bones like this, and the fracture is here, and the bone is pooping out like this. You will see it in the solving question part, okay? And finally, we have Colles fracture. Colles fracture is a common fracture in a fall of outstretched hand. So if someone is falling on an outstretched hand and they like damage the wrist, the most common fracture is Colles fracture, which is distal radius fracture. So this is the wrist, this is the radial bone, and in Colles fracture, the radius bone will completely fracture and be destroyed. Okay, so the most common fracture in fallen outstretched hand is Colles fracture, which is distal radius fracture, like this. Okay, okay. Now, all of these fractures that we have mentioned are physiological. It happens because I fall on my hand, I have a trauma, a ball hits my finger. All of this is physiological fracture, okay? There is no disease. It's just me being stupid and hits myself or whatever, okay? However, pathological fracture, our fracture happens because I have a disease. Normally, this won't happen, okay? And this pathologic fracture usually happen due to osteolytic lesion or osteoporosis. If I have osteoporosis, my bone is very weak, that will be fractured very easily. And if I have hyperparathyroidism, I will have osteolytic lesions that cause my bone to be weak and fracture will happen. So in physiologic fracture, the one that happens with trauma, as you can see, the other bones are normal. Only this one is abnormal, or only this one is abnormal. As you can see here, everything here is normal, except the fracture bone itself. However, in pathologic fracture, because let's say I have osteoporosis or I have osteolysis fibrosis cystica, the bone itself will be bad. Okay, so as you can see here, we have osteoporosis here, or we have osteostatic fibrosis cystica here, and that caused the fracture to happen. Okay, so how to differentiate between physiological and pathological? Physiological, the bone itself will be good, however, it's just fractured. In pathological, the bone itself will be weak, so it will have osteoporosis or very high bone resorption or whatever. Okay, so that's the difference between pathological and physiological fracture. Now we'll go just through some diseases, just name them. Calcific tendonitis. So here we have a tendon that attached to the humerus. Because we have hypercalcemia and we overuse this joint, we will have inflammation and then it will calcify and we will have calcific tendonitis. Just memorize this picture as calcific tendonitis. Calcification of the tendon because of hypercalcemia and overuse. Then we have something called Lick-Calf-Perthes syndrome. So this is very common in children. This is the hip joint, and they have osteonecrosis for some reason. When they are born, the blood supply is very bad, and they will have osteonecrosis of the hip joint. That's Lick-Calf-Perthes syndrome. Okay, it was a question: which of the following is Lick-Calf-Perthes syndrome? And you need to choose this one: osteonecrosis of the femur in a child. Then we have this. Normally, we have the gluteus medius and the gluteus maximus and all the gluteus muscle attached here in the femur. And because of overuse and walking a lot and running a lot, we may have tendinopathy, so tendinitis or damage to the tendon itself of the gluteus muscle. So if you got this picture of a muscle that's attached, its tendon is attached to the, I don't remember what's this called, trochanteric or whatever, of the femur, and it's inflamed, that's gluteus tendinopathy. The choice won't have gluteus maximus medius, يعني not all of them. It will have only one, which was gluteus medius tendinopathy. So just memorize the picture. Now, if you have an avulsion fracture usually doesn't happen accidentally. It's because of a hit, of a trauma, or like something, not like push, or you need to hit that area specifically. So if we have an avulsion fracture of the knee, that's a very common fracture in pediatric abuse. So it's not accidental. It's not because he fell off. It's because we damaged that area specifically. So if you have this picture and we have a pocket handle fragment like this one, which is like an avulsion fracture of the knee, that's due to pediatric abuse. So you need to choose either pediatric abuse or non-accidental injury. Okay? That's the pocket handle fragment of the knee. It's due to shear force because I damaged this area specifically. Now we have in the rest a collection of bones, scaphoid, lunate, and many others. Scaphoid is the most common in osteonecrosis of the rest, and it's the most common fractured. However, lunate is the most common dislocated one. So if you have a bone that's dislocated from the rest, like here, choose lunate dislocation immediately. Now, if we have this is a human being and this is his leg, and as you can see here, he have fracture of the femur that caused the leg to be displaced. So if someone has femur fracture or femur neck fracture, they will have their leg as externally rotated and shortening of the limb. So when fracture of the femur neck happen, the limb will go inward and it will be rotated externally. Also, we have Galeazzi fracture. Just memorize. It's a fracture of the radius with dislocation of the ulnar. So this is my hand. This is my hand. This is the ulnar bone. This is the radial bone. If we have Galeazzi fracture, I will have fracture of the radius and dislocation of the ulnar. As you can see here, the radius where is it? The radius is fractured and the ulnar is dislocated. Now we have trochanteric fracture. So this is the femur bone. This is the trochanteric of the femur bone, and if it's fractured, that's called intertrochanteric fracture. Just memorize this info randomly because it was asked. Now we have a disease called rickets. It's due to vitamin D deficiency in children. So normally you need vitamin D to mineralize the bone. So after the bone is formed, it will be weak, and so we need to mineralize it, and that's the job of vitamin D and like phosphor, calcium, and these things. So if someone or a child had vitamin D deficiency, the bone will be very weak, and because they stand on their leg, the leg will be bowed. Okay, so in vitamin D deficiency of children, they will have rickets, which is causing bowing of legs because they stand on the bone, but on the leg bone, but it's very weak, causing it to be bowed like this. And it will cause many other features like weak mineralization of the bone, epiphyseal plate widening. So this epiphyseal plate should be like more narrow, but here it's widened. Just memorize these pictures for rickets as vitamin D deficiency. The question was this picture, and this is caused due to deficiency of what? And you needed to choose vitamin D. Now we have hemangioma. Hemangioma, like not related to MSI, it's benign proliferation of blood vessels. So if I have this liver and the blood vessels in it started to proliferate, that's hemangioma. It will cause a mass of blood vessels. That's hemangioma, benign proliferation of blood vessels. Okay? If it happened in bones itself, like as we said, the bone here, and this is the bone marrow, and there's blood vessels supplying the bone marrow. If we have hemangioma of the blood vessels in the bones, it will cause this salt and pepper appearance. Salt and pepper means like black dot, white dot, black dot, white dot. Or as you can see here, black dot, white dot. That's hemangioma. Now we have something called the posterior cruciate ligament and anterior cruciate ligament. Anterior from its name, it is anterior. So anterior cruciate ligament starts posteriorly and goes anteriorly. Okay? However, PCL, posterior cruciate ligament, it starts anteriorly and it goes posteriorly. Please memorize this because this came in my exam and I got it wrong. Anterior cruciate ligament, it's anterior, so it goes anteriorly. Okay, so it ends anteriorly, but it starts posteriorly. So it starts from the back and goes up front. However, posterior cruciate ligament, it ends posteriorly, so it goes posteriorly. So it starts anteriorly and goes posteriorly. Okay, so if this is the anterior side because this is the knee, if you have a ligament that goes from anterior to posterior, that PCL. If you have a ligament that goes from posterior to anterior, that's ACL. Now, this is the picture that came in my exam. As you can see here, this is the anterior side. You have the ligament going from posterior to anterior, that's ACL injury. Here, as you can see here, it's injured. However, here, this is the anterior side. It starts anteriorly and goes posteriorly, and it's injured, that PCL injury. Please memorize them by heart. Now we finished all sport medicine diseases. Now we will talk about muscle diseases. It's only one important for OSPE. It's called dermatomyositis. So it's inflammation of dermato, which is skin, and myositis, which is the muscle. So dermatomyositis is autoimmune inflammation of both muscle and skin. Now for the muscle part, it just caused proximal muscle weakness. Proximal muscle are the chest muscle and the hand muscle. Like they are proximal to my head, okay, or proximal to my core. So in dermatomyositis, it affects both skin and muscles. In muscles, it causes proximal muscle weakness. For the skin, it causes three presentations that are very important to memorize and know. First, we have Schawel sign or V sign. So I have inflammation of my skin, of the chest and the back. That's Schawel sign or V sign. Then I have heliotropic rash, which is inflammation around my eye. Finally, I have Gottron papules, which is accumulation of papules and plaques in the like this surface of the hand. Okay, so dermatomyositis, inflammation of both the skin and the muscles. For muscle part, it causes proximal muscle weakness, so I can't raise my hand. Okay, on the derma part, cause three things: Schawel sign or V sign, heliotropic rash around the eye, and Gottron papules on the hand surface. Okay. Lab wise, they will have high CKMB, which is an important enzyme in the muscles, and high aldolase. Not that important, okay? The important one are these three, which is the most important one is the first one. They will have high anti-GO1 antibody, anti-MI2 antibody, and anti-CRB antibody. These are very specific for dermatomyositis, especially anti-GO1. Histo-wise, خلاص, I won't go through it because and you need to know it to compare it with the other disease, okay, which is polymyositis. This picture show like it's a table, let's say, summarizes each disease and its antibody. Just focus on the red one, like SLE is anti-DSNA, anti-Smith, rheumatoid arthritis is anti-CCP, and so on. Yani, I thought of putting it because it is helpful. Now we will go to a big thing called bone tumors. Just a sec, break for me. All right, let's continue. Okay, with bone tumors. All right, for bone tumors, this is the bone. This is the cartilage. This upper part is saying. This upper part is the epiphysis. Epiphysis. Okay, the under part is called metaphysis, and here the line between them is the epiphyseal line. So if you have a bone, and this is the epiphyseal line, above it is epiphysis, under it is metaphysis, and this long bone shaft is diaphysis. Okay, bone is having two cells, osteoblast and osteoclast. Osteoblast is one cell, like have one nucleus, and it causes bone formation. Osteoclast is having multiple nucleus, as we said, it's multi-nucleate giant cells, and cause breakdown of bones. Okay, now let's start with bone tumors. Bone tumors usually are secondary to metastasis. So we have two types of tumors, primary and secondary. Primary is a tumor in the thing itself. So let's say primary liver cancer is a cancer in the liver from the liver. However, secondary liver cancer is cancer in the liver due to metastasis from somewhere else. So bone cancer can be primary, which is cancer from the bone itself, or can be secondary, which is a metastasis from another like cancer. Okay. Most common cause of bone cancer is secondary. Okay, this was an MCQ question. Most common cause of bone cancer is secondary. Most common cause of secondary bone cancer is prostate cancer. Okay, memorize these things. Okay, now we have two types of secondary bone cancer, which is caused due to metastasis. It can be osteolytic, which is high osteoclast activity, causing a very lytic lesion, which is the black ones, or it can be osteoplastic metastasis, which is metastasis of the osteoblast. Like this metastasis goes to the bone and causes proliferation of the osteoblast, not osteoclast, and causes very high bone formation. Normally, bone is not that white. Okay, so that's the two types. Osteolytic metastasis causes high osteoclast and high lytic lesion, which is black, or osteoplastic metastasis, which is high proliferation of osteoblasts, and it causes these white sclerotic lesions. This is another picture. Normally, bone grossly looks like this, not white. Okay? So don't say this is osteoplastic metastasis. No, usually if it's osteoplastic, the whole bone will be like this. However, here it's white because this is fat deposition. So this is osteoclastic or osteolytic metastasis. Okay? Because osteoclast increased, it destroyed the bone, and now we have fat deposition, and that's osteoclastic metastasis, most likely due to prostate. Now we will start with bone tumors. Bone tumors, the primary one, can either be benign or malignant. Benign doesn't cross the membrane, they are not very scary, they have good prognosis. On the other hand, malignant, they are very like vicious and have bad prognosis. Now, the first benign bone tumor is osteoma. Osteoma is benign proliferation of bone forming cells, which is osteoblasts. Okay, so in osteoma, we have benign proliferation of osteoblasts. Okay, location most commonly in the skull and the face and the jaw. So osteoma is just in the face. It starts with an osteoma, so it's in the face, skull, facial, jaw. Okay, histology resembles normal bone, grows, it's just whitish mass, as you can see here, it's just whitish mass, and here it's just like normal bone. Okay, if we have multiple osteomas, that's Gardner syndrome. I won't go through that, just know what's that. Now we have enchondroma. Okay, the bone is either made of bone cells or cartilage cells. Enchondroma is benign proliferation of chondrocytes, which is the cartilage cells. Okay. Now, if you have benign proliferation of cartilage cells, you will have a lot of cartilage formation. The disease called enchondroma, so it's inside the bone. So we will have formation of cartilage masses inside the bone. As you can see here, that's cartilage inside the bone. Grossly, we will have multiple cartilage inside the bone. On an X-ray, we have black lesion. Okay. And in histology, we will have a lot of chondrocytes inside the bone. Now we also have osteochondroma. That's still benign because it ends with oma. Okay, so just to know, sarcoma are cancerous. Oma or adenoma, oma is benign. So this is osteochondroma, that's still benign. But look at the name, it's osteo and chondro. So it's both bone and cartilage. Osteochondroma is benign proliferation of a bony like core surrounded by cartilage. So osteochondroma is bony core surrounded by cartilage cap. Okay, as you can see here, it's a bony core surrounded by cartilage cap. Bony core surrounded by cartilage cap. Okay, it's on an X-ray, it's like a mushroom head going through the out of metaphysis. Okay, so osteochondroma, benign proliferation of the bone and the cartilage, causing bone core surrounded by cartilage cap. On an X-ray, it's like a projecting mushroom from the metaphysis. Looks very like cute, I would say. It's simple. Yani it's benign. So we said everything here. Now we'll talk about malignant bone tumors. It's neoplastic proliferation of the bone cells or the chondrocytes, which is the cartilage cells. First, we have osteosarcoma from the name. Sarcoma means malignant. Osteo means it's from the bone itself. If you remember, osteoma, it was from bone formation, bone forming cells, which is osteoblast. So osteosarcoma will be malignant proliferation of bone forming cells, which is osteoblasts. So in osteosarcoma, we have malignant proliferation of osteoblasts that causes like very weird bone formation in the metaphysis. Okay, so grossly, we will have neoplastic mass growing from the metaphysis. Okay, the mass is made of bone, osteoblast and osteoid. If you have malignant proliferation of osteoblast, and this osteoblast will secrete osteoid, so in histology, we will have osteoblast and osteoid. Okay, histology-wise, the osteoblast look like a spindle shape, so it will be spindle-shaped osteoblasts. Simple. Osteosarcoma, malignant proliferation of osteoblasts. It occur at the metaphysis. Okay, it will cause in histology osteoblast and osteoid, and it's spindle-shaped cells. Now, if we looked at an X-ray, this is the bone, and the bone is surrounded by something called periosteum. If we have a malignant tumor growing through the periosteum will like shift outside. However, it doesn't break it, so we'll have something called Codman triangle. Here's the mass, and this is the periosteum being pushed out. Okay, so osteosarcoma causes Codman triangle, which is the mass growing outside of the metaphysis covered by the periosteum. It's due to lifting of periosteum. Also, it has something called sunburst appearance, like this. And on histology, it's spindle-shaped osteoblasts with osteoid. So memorize, osteosarcoma on an X-ray, it will grow, but it doesn't rupture the periosteum. So it has Codman triangle, and it also have sunburst appearance. It like after it break the periosteum. In histology, it's spindle-shaped cells with osteoid. So, final time, osteosarcoma, malignant proliferation of osteoblast. The risk to develop osteosarcoma is a patient having Paget disease, radiation, RET, not that important. The location is very important. Most common location of osteosarcoma is the knee joint, the metaphysis of the knee joint. If you look asla in the pictures, except this one, all of them are the knee joint. Okay? So, osteosarcoma, most common location is knee joint. That's very, very important. It presents as pathologic fracture, swelling, bone pain, imaging, destructive mass, sunburst appearance, lifting of periosteum, Codman triangle, histology, spindle-shaped, and yeah. Osteosarcoma causes formation of a very weak bone because it's caused just rapidly developing bone. So it causes common or like frequent fractures. Now we have something called giant cell tumor or osteoclastoma. In osteosarcoma, it was neoplastic proliferation of osteoblasts. In giant cell tumor, what cell is giant cell or like multinucleated cell? It's osteoclast. So giant cell tumor or osteoclastoma, it's neoplastic perforation of osteoclast. It leads to high bone resorption, not high bone formation, high bone resorption. In contrast to osteosarcoma, it is in epiphysis, so it's above the epiphyseal plate. On an X-ray, if you have giant cells, which is osteoclast, and it's destroying the bone, we will have this soap bubble sign. Okay? So giant cell tumor will have soap bubble sign. And on histology, we have high amount of multinucleated cells, which is osteoclasts. Then we have chondrosarcoma. Sarcoma means malignant. Chondro means it's from cartilage. So chondrosarcoma, it's neoplastic perforation of chondroblasts, which is the cell of cartilage. Grossly, it looks grayish or blue mass because cartilage usually look gray or blue. And it's out of the metaphysis. And histology, it looks like atypical blue chondroblasts. That's it. Chondrosarcoma, malignant perforation of chondroblasts. It causes blue or grayish mass out of the metaphysis. And on histology, it's blue atypical chondroblasts. Now we have Ewing sarcoma, and as you can see, the name is Ewing. So remember Ew, okay? Because it's very ugly tumor. So Ewing sarcoma or Ew sarcoma, it's neoplastic perforation of poorly differentiated cells. So it's bad cells or ugly cells that are derived from neuroectoderm. So normally, all the cancers we have in the bones are from bone itself except Ewing sarcoma because it's disgusting. It's coming from another place, which is the neuroectoderm. So Ewing sarcoma is neoplastic of poorly differentiated cells, which is ugly, and it's derived from neuroectoderm, which is a disgusting place, not like the bones, which is a good place. It affects the children, and who likes children? Ew. Okay, so it's Ewing sarcoma affecting children, and the location is diaphysis, which is if you looked at the bone, the upper part is epiphysis, middle part is metaphysis, and the lower part, the most Ewing part, you get the point, the most disgusting part or the most lower part is the diaphysis. So Ewing sarcoma is poorly differentiated cells out of the bone, which is neuroectoderm. It affects children because it's Ewing, and it affects the lower part of the bone because it's disgusting. So the upper part doesn't like it. That's why it affects the lower part. In histology, it's full of small round blue cells separated by septa. So it's like this. Just remember, if you have this very ugly appearance, it's Ew, which is Ewing sarcoma. On an X-ray, it has this onion skin appearance. So you know the onion, it has so many layers. Yeah, this appearance is similar to the onion layers. So it has onion skin appearance. And come on, who likes onion? So ew again, okay? It's CD99 positive, and this is a marker for the neuroectoderm, and it's caused due to a translocation. And who likes translocation? Again, it's ew. So final time, Ewing sarcoma or Ew sarcoma is due to poorly differentiated disease, which is ugly, derived from neuroectoderm, which is also ugly. It affects the children, which is also ugly. It's in the diaphysis, which is under the bone, like at the lower part, so the upper part doesn't like it, which is also ugly or ew. In histology, it's more round blue cells scattered, so also it's ugly. And on X-ray, it's onion skin appearance, which is also ew. And finally, it's due to a translocation, which is, come on, who likes translocations? Another ew. This not related to cancers. I just found this picture in an OSPE exam. I just want to put it in somewhere. This is the only place that maybe fits. If we took an like fluid analysis or whatever, and we have a lot of iron, then we have high ferritin. That's it. They had this picture, and what is this? I do need to say high ferritin. That's it. We finished with the MSK. Please, if you have any question, you can contact me. You can repeat the video, do whatever you want. And now we will start with dermatology. And as you can see, the theme also changed. So now, just a sec. All right, now we will start with derma. Yep, it's working. Yeah. Now we'll start with derma, and it's way easier than the MSK because it's just collection of diseases, and I'm explaining them, and inshallah, it's very easy. So let's start. Okay, so first we will start with derma basics. So now we have in the skin, we have two layers. The first layer is called epidermis, and this whole thing is the first layer called epidermis. And under it, we have the second layer, which is called dermis. Okay? So the epidermis is the skin layer that made of keratinocytes. Keratinocytes are squamous cell epithelium covered with keratin, and this whole thing is made of keratinocytes. Now, the epidermis is divided to four layers. First one is the one in the bottom, okay? It's the basal layer called stratum basalis, okay? This layer, stratum basali. Okay, it's the basal layer. It's a germ cell layer that have all the stem cells that will give rise to all of these cells. Okay, so first layer is stratum basale, which is the basal cell layer that have all the stem cells that will give rise to all the cells in the epidermis. Second layer is this whole thing called stratum spinosum. Then the third layer is this one here, the one just below this whole keratin thing. So it's this layer called stratum granulosum, and it's the darker one. Okay. And finally, we have the stratum corneum, which is this big keratin layer. Okay. So epidermis is made of four layers. First one is stratum basale, which is the basal layer attached to the basement membrane, and it's the one connected to the dermis. It has germ cell layer that give rise to all the cells above it. Then this whole white thing or light thing called stratum spinosum. Then this darker layer is stratum granulosum. And finally, this whole keratin part is stratum corneum. Now, there is no blood vessels in the epidermis. There is no nutrition that reaches to the epidermis from any blood vessels except from the one in the dermis. There is no lymphocytes. There is no immune cells. It's just cells and keratin. Okay? So, since the blood vessels doesn't reach, the one that's very far from the blood vessels will be dead, which is the stratum corneum. Stratum corneum is full of dead cells. It doesn't even have a nuclei. Okay? That's the epidermis. Okay? Now, epidermis, along with all the keratinocytes and the four layers, it has two extra cells. First one is melanocytes. I will have it in another slide. Melanocytes is the one that secrete melanin, responsible for the color of your skin, okay? And it usually grows like this, radially, horizontally. Other one is called Langerhans cells, which is an immune cell, okay? This Langerhans cell is not literally an immune cell because it doesn't, this epidermis doesn't have immune cells. It's, we call it antigen presenting cell, just like dendritic cell, and it take the pathogen and present it to the immune cells in the dermis. Okay. Third cell, صح, there are three. It's called Merkel cell, which is a nerve ending, and it's just responsible of the sensation if you touched something. I'll have a slide about them later on. This slide also shows the other parts of the epidermis. So the upper part, the dead part, is stratum corneum. The dark part under it is stratum granulosum. This whole thing is stratum spinosum, and the basal cell layer is stratum basale. Then we have the dermis. Dermis is full of collagen, stroma, blood vessels, lymphocytes. So it's just full of interstitium cells, which is collagen, stroma, and these things. It's just under the epidermis. It's full of blood vessels and lymphocytes, and it's connected to the dermis with something called dermal epidermal junction. Okay? Now, I also want to mention that we have two junctional cells. Here in the epidermis, it's full of cells, right? These cells must be connected to each other somehow, and they are connected through something called desmosome. Okay, so desmosome connect the epidermis cell. However, here, between the epidermis and the dermis, we need a stronger cells. Desmosome is not enough. So between the dermis and epidermis, we have something called hemidesmosomes. Okay? So between dermis and epidermis, we have hemidesmosomes, and between the epidermal cells, we have desmosomes. Everything I said is written here. So epidermis made of four layers. It has no blood supply, no immune cells, and the upper part is made of dead keratin because blood vessel doesn't reach here. يعني مستحيل. Nutrition can't reach here. It's made of four layers: stratum basale, spinosum, granulosum, corneum. And stratum basale is the germ cell layer that gives rise to all layers above it. It has melanocytes at the base, make pigments. It's spread horizontally, which is called lentigo. I'll talk about this later. Epidermal cells are connected together by desmosomes. The part of the epidermis that are this epidermis is kind of projecting into the dermis. It's not like they are flat like a cake. Okay, it has some part projecting down, and these called epidermal ridges. So the part of the epidermis that's projecting down is called epidermal ridges. On the other hand, the dermis is the bottom layer of the skin. It contains stroma, collagen, blood vessels, white blood cells, lymphocytes. The part connecting the dermis with the epidermis called epidermal junction. Epidermal junction is full of hemidesmosomes. So the part connecting the dermis with the epidermis is called hemidesmosomes. The part of the dermis projecting into the dermis is called dermal papillae. So as you can see here, some parts of the epidermis are projecting into the dermis. On the other hand, some parts of the dermis are projecting into the dermis, and that's called dermal papillae. So part of epidermis projecting down, that's epidermal ridges. Part of the dermis projecting up are dermal papillae. Okay? There is no keratin in the dermis, no melanocytes, and during inflammation, because the dermis have blood vessels and have lymphocytes, during inflammation, dermis will be full of lymphocytes. Okay? Now, I also mentioned that the epidermis have three extra cells. The first one is Langerhans cells. Langerhans cells are antigen presenting cell. It's not like an immune cell that cause inflammation. It just take the pathogen and take it to the dermis to present it to the immune cells. Okay, so in the epidermis we have Langerhans cells. One important feature about Langerhans cells that they have this tennis racket shape in under the electron microscope. So they put a picture of this tennis racket shape and ask, what is this cell? This is Langerhans cells. In which layer it is? In epidermis. And also the slight cells in the epidermis. Okay, that's Langerhans cells. We also have Merkel cells, which is a nerve ending that's important for sensation. I don't have a picture for it because we can't visualize it, but it's like a cell here that is important for sensation. A question will be like, which of the following cells are important for sensation in the skin? The answer is Merkel cell. Now we will talk about some gross terminology about like the derma. First, we have macule. Macule is a flat, not raised lesion, and it's small, less than 5 millimeter. Okay. By the way, use this number from your slides as a reference. Okay. These numbers are the one in step. So I'm not sure if they are the same that in your slides. I checked. I remember they are the same, but please double check. Okay. Because some people say it's below one something. Okay. So just double check it. Macule is flat, not raised, small lesion. On the other hand, patch is a flat, not raised, big lesion. So if you have a flat raised lesion, if it's small, that's macule. If it's big, that's patch. Okay? That's important because wallahi, in my batch, in my exam, he brought these questions. A flat, not raised lesion below whatever centimeter. It is, and you need to choose macule. Okay? So if it's flat and small, that's macule. If it's flat and big, that's patch. Now, if it's not flat, if it's raised, okay? However, it's small, that's papule. If it's not flat, it is raised but big, that's nodule. So, if you have a flat and small, macule. If you have flat but big, patch. If you have raised but small, papule. Raised but big, nodule. And finally, we have plaque, which is collection of papules. It's collection of papules and nodules with collection of like raised stuff. So we have a papule here, nodule here, papule here, nodule here. If we collect them all together, that's a plaque. Now, fluid-filled lesions. So all of the things we now explained, it's just a lesion of erythema or discoloration. However, here it's fluid-filled. So we have the cell and it's filled with fluid. Okay. First, we have vesicle. Vesicle is a small fluid-filled lesion. So it's just like a balloon, but it's a small one. Okay, small fluid-filled lesion. If it's big fluid-filled lesion, then we call it bullae or blister. Okay, so small fluid-filled, that's vesicle. Large bullae or blister. Now, if it's not filled with fluid, but it's filled with pus, which is neutrophils and immune dead cells, then it's pustule. Okay? And finally, we have wheals or hives, which is transient raised edematous lesion. It blanch when we press it. So a vesicle or bullae or pustule, you have the skin and this like a raised lesion like a balloon. But in hives, the whole thing will be filled with fluid, not just like a balloon. And it's transient, raised, and edematous, and it's important in like immune reaction. Scale is dry, itchy, scaly lesion due to accumulation of keratin. So normally we have keratin here, which is the dead keratinocytes, and normally our body removes it, and like by movement it's gone. But if it accumulates, it will cause this dry, scaly lesion, which is itchy also, and it's called scale. However, we have something also white, which is called lichenification, which is thickening of the skin due to chronic rubbing of or scratching. So, scale is due to high keratinocytes. We can just remove it because aslan it's itchy. If we kept itching, and by chronic itching, the whole skin is destroyed and fibrosis happen, that's lichenification, which is thickening of the skin and fibrosis due to chronic rubbing. Now, if we rub the scaly lesion and we have blood under it, that's oxycoriation. Okay, linear erosions caused by scratching. Okay, so scale is due to accumulation of keratinocytes, dead keratinocytes. It's white, it's very itchy. We kept itching and we took it off and caused an erosion and blood to come out. That's excoriation. After all of that, fibrosis will happen, and that's lichenification. Okay? Finally, we have onycholysis, which is separation of the nail from its nail bed. Onycholysis. Now we have erosion, which is loss of the epidermis. So we said this is epidermis and this is dermis. If we damage the epidermis only and removed it, that's erosion. Okay? It doesn't reach the dermis. It's only the epidermis. However, ulcer is removal of the epidermis and dermis. So ulcer is loss of epidermis and dermis. So if the damage is only in the epidermis, that's erosion. If it reached the dermis, that's ulcer. Now let's go to histology terminology. Now we have this cell which is filled with fluid. The cell itself is filled with fluid. That's hydropic swelling. Hydropic swelling is intracellular swelling, like swelling in the cell itself due to accumulation of fluid in it. On the other hand, we have spongiosis, which is accumulation of fluid between the cells. Okay, so spongiosis is dissociation of epidermal cells. Epidermal cells should be connected, but if we accumulate the fluid between them, they will dissociate, and that's spongiosis. Please know the difference. If the fluid is inside the cell itself, that's hydropic swelling. If the fluid is between the cells, that's spongiosis. Now we have something called acantholysis. Okay, acantholysis is dissociation of the epidermal cells. Okay, if it's caused due to fluid, that's spongiosis. If it's not caused due to fluid, it's caused due to damage or something, that's acantholysis. Okay, so acantholysis is dissociation of the epidermal cell layer, not the dermis, not from the epidermis and dermis. No, it's between the epidermal cell layer itself, like stratum corneum and basalis, stratum basalis and granulosum. If there is a separation, that's acantholysis. On the other hand, acanthosis means hyperplasia of all epidermis cell layer. We said the epidermis is made of 4 layers, right? If we have hyperplasia of all of them, that's acanthosis. So acanth means epidermis. If it's acanthosis, means hyperplasia of the whole epidermis. If it's acantholysis, now separation of the epidermis. Okay? Exocytosis is when the immune cells that are in the dermis reach the epidermis. Normally, epidermis doesn't have lymphocytes and white blood cells, but in inflammation, they may reach it, and that's exocytosis, which is lymphocytes going from dermis to epidermis. Now we have hyperkeratosis. We said acanthosis is hyperplasia of all the epidermis. However, hyperkeratosis is hyperplasia of the keratin layer itself, which is stratum corneum. So hyperkeratosis is increased thickness of the keratin layer itself, which is stratum corneum. Not the whole thing, just the keratin layer. Now, normally we said the stratum corneum is full of dead cells, and dead cells doesn't have nuclei. So as you can see here, the keratin layer doesn't have a nuclei. However, in some diseases, we will have something called parakeratosis. Parakeratosis is hyperkeratosis, which is increased thickness of the stratum corneum with retained nuclei. So the cells are not dead, they have nuclei. So I want you to differentiate between these two. Hyperkeratosis is increased thickness of the keratin layer, but still the cells are dead. However, parakeratosis is hyperkeratosis of the keratin layer. However, the cells are not dead and they have nuclei. Oh God, wait. So they have retained nuclei in parakeratosis. Now, normally the keratin layer is the last layer, the full of dead cells and whatever. Now, what if we have keratin inside the epidermis itself? So epidermis is made of four layers. The keratin is the dead one. What if the dead cells are in between? That's called dyskeratosis. High keratin deposition in between the epidermis, not the dermis. It's keratin, which is the dead cells, but in the epidermis itself. We have something called hypergranulosis. We said acanthosis is hyperplasia of all the cells, of the all of the layers. Hyperkeratosis of the keratin layer. Hypergranulosis is hyperplasia of stratum granulosum only. Stratum granulosum is the dark layer. It should be thin, but here it's very wide and big. That's hypergranulosis. Lentigious is the horizontal or radial growth of the melanocytes. Melanocytes are the pigmentation cells. They are brown and it's like one or two cells. Okay. However, if we have it fully here, or like here, that's called lentigious or horizontal radial growth of it. Now, as we said, this is the dermis and this is the epidermis. The dermis may project into the epidermis with something called dermal papillae, which is this. This is dermal papillae. If the epidermis around the dermal papillae is very thick, then that's called papillomatosis. Okay? It's hyperplasia of the dermal papillae and the epidermis around it itself. Okay? Finally, we have vacuolization, which is inclusion body in the dermis, in the upper epidermis. Normally, epidermis is full of keratinocytes. Doesn't look like this. However, if we have inclusion body, which is like black cell surrounded by light cytoplasm, that's inclusion body. That's called vacuolization. I hope everything is clear. Now we'll start with the diseases themselves. And if you know the basics, the diseases are very easy. First, we have urticaria or hives. Imagine you ate peanuts and you have peanut allergy. You will have anaphylactic reaction. So what's happen in anaphylactic reaction? It will be acute. So it's all of the sudden. It's not like progressing. No, it's all of the sudden. You will have an anaphylactic reaction. You will have bradycardia and you are barely breathing. And when you look on your skin, you will have hives. Hives or wheals are raised edematous plaques. Okay? Which is wheals. Okay? So in urticaria or hives, it's acute, so sudden anaphylactic reaction that cause raised edematous plaques. Okay? It's very red like this. And it's acute and very sudden. On histology, we said the blood vessels doesn't reach the epidermis. So the epidermis is intact. As you can see here, the epidermis is all good. Okay? However, the dermis, we will have an anaphylactic reaction. So the blood vessels will vasodilate and the immune cells will get out of it and we will have like this disorganization in the dermis. So urticaria or hives, it's type 1 hypersensitivity reaction, which is like anaphylaxis. It's mediated through mast cell, histamine, and IgE. I hope like you now finished POD, you know what are these and you know what type 1 hypersensitivity reaction. It's acute, very sudden, and it's associated with anaphylaxis. And in histology, the epidermis is intact. However, the dermis is disoriented with full of edema, blood vessels, and inflammatory cells. On the other hand, we have atopic eczematous dermatitis. This is also a type 1 hypersensitivity reaction, but unlike urticaria, which is acute, like because you eat peanuts and you have peanut allergy, this one is chronic. It's because you are, let's say, allergic of your own bed sheets, okay? And you're sleeping on them a lot, and you will have a chronic allergic reaction. It doesn't start all of the sudden, like not once you sleep on your bed sheet, you will have it. However, it's chronically, or progressively. So when you sleep a lot on your bed sheet, you will have this allergic reaction. It's type 1, so it's mediated through mast cell, histamine, and IgE. However, symptoms are chronic and gradual. The location of it, in infants, it's on their cheeks and extensor surface, okay? So as this child, he has like the chronic reaction here on his extensor surface and cheeks. However, in adults, it's on the flexor surface. So like here, this the flexor surface, or here, that's a flexor surface. Now, what happens in it? It has stages, okay? In the first stage, the inflammatory cells will reach here and causes spongiosis, okay? So it will cause edema in the epidermis. That's spongiosis. And later on, it will cause acanthosis and fibrosis and these things, okay? So first stage is spongiosis, as you can see here. That's spongiosis, accumulation of fluid and immune cells in the epidermis. And then it will have acanthosis and lichenification, which is like this white scaly region. So there are two diseases caused by type 1 hypersensitivity reaction. First one is urticaria or hives. When you eat something you are allergic to, you will have acute sudden reaction. Your body will be full of red plaques and papules, and then it will be gone. It only affects the dermis. However, in atopic eczematic dermatitis, uh, it's due to chronic exposure to the atopy, and then you will have inflammation. If it's in child, it's in the cheeks or extensor surface. However, in adults, in the flexor surface. Histology, it's caused spongiosis, so it affects the epidermis. It causes edema in the epidermis, which is spongiosis, and then later on it causes acanthosis and lichenification, which is like this white scaly region. So it starts red, but later on it will be white. Then we have contact dermatitis. Contact dermatitis is type 4 hypersensitivity reaction. You may not know it's this. That's fine. I don't want you to know what's that. I just want you to know two things about type 4 hypersensitivity reaction. First, it's not mediated through mast cell and histamine. It's mediated through lymphocytes. Okay? So type 4 hypersensitivity reaction is mediated through lymphocytes. It's due to contact with something that is poisonous or damaging to your skin. So some people are يعني allergic, but not like the type 1 hypersensitivity. They are allergic to latex gloves اللي هم القفازات sterile gloves. Okay, so when they wear them, after that they will have this inflammation in their hand. Some people are allergic to nickel, so when they wear a nickel ring, they will have inflammation in the ring area. Some people get exposed to poison ivy, so they will have contact dermatitis. Contact dermatitis, it's type 4 sensitivity reaction mediated through lymphocytes. Now, how does it present? It's erythematous, plaques, and vesicles only at the contact area because it's called contact dermatitis. Now, in urticaria or atopic dermatitis, it's all over the body. However, contact dermatitis is just at the point of contact. So if you wear gloves, you will have it on your hand. If you wear a nickel ring, it's just at the ring area. It is erythematous papules and vesicles, okay? It has linear or geometric pattern, so it's only at the area of exposure. That's what geometric pattern mean. And histology, spongiosis, vesicles, and exocytosis. Okay, so similar to atopic dermatitis, spongiosis, and these things. Okay, so now we have seborrheic dermatitis. I want to explain something that normally I will explain it later on in the micro part, but normally if we have this is the skin and this is the hair follicle, okay? And surrounding the hair follicle, we have glands called sebaceous glands. Sebaceous glands secrete oil that makes our skin oily, okay, not dry. So this is the normal histology. Normally, we have something called malassezia, which is a fungi that lives on our skin. It's normal to live there. It has to live there. It protects us from bacteria and other organism, and it prefers the oily environment. Okay. Now, for any reason, if we have increased secretion of oil from sebaceous gland, we will have oil accumulation. The Malassezia fungi will favor this environment and it will cause inflammation of the whole area. So, seborrheic dermatitis is inflammation of the hair follicle caused due to high secretion of sebaceous gland that causes Malassezia furfur to overgrowth and causes the inflammation. It's not a disease of the sebaceous gland. Instead, it's inflammation caused due to high secretion of sebaceous gland. It usually occurs in the area that has high oil, so behind the ear, on the cheeks, on the forehead. Okay? So, normally our skin has Malassezia furfur, which is a fungi lives on our skin. In seborrheic dermatitis, we have increased secretion of sebaceous gland. Melasthesia will overgrowth and cause inflammation of the hair follicle. Grossly, we will have erythema around oily surfaces. In histology, we have acanthosis, as you can see here, and inflammatory infiltrate around the hair follicle. Now we have something called erythema multiforme. I just want you to know two things about erythema multiforme. If you saw a targetoid lesion, like this one, like a lesion with a target sign, this is erythema multiforme. Okay? Second thing is the inner part is dark because it's full of dead cells. Okay? So the targetoid lesion is like a target sign. The inner part is dark because it's full of dead cells. These dead cells are either CD8 positive or the dead cells themselves, because CD8 positive kill the cells. So the target sign in the middle is CD8 positive or the dead cells. Okay. Around it are other inflammatory cells like CD4 and neutrophils and whatever. Okay. In histology, for erythema multiforme, we have something called interphase dermatitis. What does that mean? It means that we have a lot of lymphocytes in the epidermal dermal junction. Okay? We don't have any lymphocytes in the epidermis. However, we have high amount of lymphocytes in the dermal epidermal junction. So, erythema multiforme, three things. First, targetoid lesion. Okay? Second thing, the target sign itself in the middle, it's full of dead cells or CD8 positive cells. Finally, on histology, we have interface dermatitis, which is lymphocytes at the dermal epidermal junction. That's not exocytosis, because exocytosis means lymphocytes in the epidermis. However, in erythema multiforme, you have interface dermatitis, which is lymphocytes in the dermal epidermal junction. Now we will start with like big diseases, okay? And I have mnemonic for each one. First one is psoriasis, okay? Psoriasis causes these salmon like plaques on the hand. Why does psoriasis happen? Psoriasis happen due to autoimmune excessive proliferation of keratinocytes. So normally you have these keratinocytes proliferating like every 3 days. In psoriasis, we have autoimmune excessive proliferation, so it proliferates every single day. So we will have a lot of keratin or dead keratin on the outer part, and this caused these well circumscribed, scaly, salmon-colored plaques. So if you saw someone with salmon-colored plaques, that's definitely psoriasis. Later on, we will remove these plaques and we will develop infection, and this will develop and become pustules. So in psoriasis, we have autoimmune excessive proliferation of keratin that causes the salmon-colored plaques. Later on, it will become like pustules. It also affects the nails and causes onycholysis and nail pitting, which is like separation of the nail pit and nail pitting. So, psoriasis, autoimmune excessive proliferation of the keratinocytes, causing these salmon-colored plaques and pustules. It also affects the finger and causes onycholysis and nail pitting. Now, histology-wise, it's a very common SAQ question to ask you what happens in psoriasis in histology. I have this mnemonic, which is AABC. Okay? Psoriasis, AABC. Okay? A is acanthosis. So in psoriasis, we have acanthosis. We said psoriasis, autoimmune proliferation of the keratinocytes. So of course, we'll have acanthosis, which is hyperplasia of whole epidermis. Okay? Then we have something called OSPE sign. Normally, we have this whole epidermis and this dermis. And the dermis have these papillae, okay? However, above the papillae, we have a lot of epidermis. However, in psoriasis, these papillae will grow very upward. And look here, the epidermis is very narrow. Besides the keratinocyte, the epidermis itself is very narrow. So in psoriasis, we have something called OSPE sign. It's like when you scratch the salmon-colored plaque, it will bleed immediately, but only on the side. Why? Why do we have pinpoint bleeding? Because the in psoriasis, the dermis will be very close to the keratin part because of thinning of the other parts. Okay, so once you remove the keratin part, you will have pinpoint bleeding, and that's OSPE sign. So A, acanthosis. Another A is OSPE sign, which is pinpoint bleeding after removal of the plaque due to thinning of the epidermis due to high growth of the dermal papillae. Then the P is parakeratosis. As you can see here, we have the nuclei retained in the keratin. And finally, C, which is collection of neutrophils in stratum corneum, which is abscess. Okay? So psoriasis, four things. First one is acanthosis, which is hyperplasia of the whole layer. Another A is OSPE sign. I explained what's that. Parakeratosis, which is nuclei in the epidermis. And C is collection of neutrophils in the stratum corneum, which is abscess. It has a name, Minoru abscess or whatever, like this. The treatment of psoriasis, I'm not sure if this is included. It was included in my days. Corticosteroids, that's included in your slides. Vitamin D, that's weird. I just want to mention it because apparently vitamin D stops the autoimmune inflammation and proliferation of keratinocytes. So psoriasis treatments, corticosteroids, and vitamin D. Now we have lichen planus. It is the 5BSS mnemonic. So we have two mnemonics, the AABC, that's psoriasis, and lichen planus is the 5BSS. 5B is for lichen planus is it's pruritic, polygonal, planar, purple papules. So it's a papule that's purple, pruritic, which is very itchy, and polygonal. Okay, that's lichen planus. On gross, it's 5Bs, which is pruritic, polygonal, planar, and purple papules. Okay? The SS is first, it has white stereo. So it is purple, but it has white lines. That's stereo, which is Wickham stereo. And in histology, it has something called sawtooth appearance. It's caused due to inflammation of the dermal epidermal junction that looks like a sawtooth. Normally, the dermal epidermal junction is like this. However, in lichen planus, it's very sharp, so it's called sawtooth appearance. So I only want you to know the mnemonic of lichen planus, 5BSS. The 5B are pruritic, polygonal, planar, purple papules. Okay? The first S is stereo, which is white lines in the papule itself. And the second S is inflammation of a dermal epidermal junction that causes sawtooth appearance. Now we will go to go to blistering disorders. All right, now we will go to blistering disorder. Okay, so as we said, we have epidermis and then dermis. The epidermis is connected with each other by desmosomes. The epidermis and dermis are connected by hemidesmosomes. Okay? If I went and damaged the desmosomes, the epidermis will separate from each other and fluid will accumulate and cause blister formation. This blister is very weak because it has half of the layers. Like if I damaged here, and we have four layers, two here and two here. If I damaged in between, I will only have two layers, and this blister will be very weak. So if I touched it, it will destroy. It will be destroyed. Okay, and that's called Nikolsky sign positive. Nikolsky sign positive mean that if you touched a blister and it popped, that's Nikolsky sign positive. Okay. On the other hand, hemidesmosomes are connecting the dermis with the epidermis. If I have damaged the hemidesmosomes, the epidermis will be separated from the dermis, and I will have a blister formed here. However, these blisters have all the four layers because I damaged the epidermis and dermis connection, not damaged the epidermis itself. So all the four layers of the epidermis are still connected, and so this blister will be very strong. And if I touched it, it will يعني not pop, which is Nikolsky sign negative. Okay? So now let's start. First disease, wait. Yeah. First disease called pemphigus vulgaris. Pemphigus vulgaris is autoimmune antibody against desmosomes. Okay? So in pemphigus vulgaris, we have autoimmune antibody that go to desmosomes, destroy them, and so it causes separation of the epidermis. So as you can see here, the epidermis is separated and it's full of fluid. However, there are still lines of epidermis here, which is stratum basale and some stratum spongiosum, and the other part is above. Okay, because of that, because it has two layers above and two layers down, if I touched it, it will pop and it will cause erosions. Okay, so it is Nikolsky sign positive. So in pemphigus vulgaris, we have autoimmune antibody to desmosomes, specifically something called desmoglein. Okay. This causes dissociation and acantholysis between the epidermal cell layer and cause formation of thin blisters that easily ruptures and causes erosions, which is Nikolsky sign positive. Now, where does pemphigus vulgaris occur? It occur in like all the body and the oral cavity. يعني you saw many people with these lesions like this one. يعني it may أصلا happen to you once that you have erosion in your mouth. So that's not necessarily pemphigus vulgaris, but I'm saying that it's common in the oral cavity. Just remember it that way. That's, oh yeah, I remember having erosion in my mouth. So that's pemphigus vulgaris. In histology wise, we have suprabasilar blisters. What does suprabasilar mean? That the blister is above the stratum basale because it's separated the layers above it. Okay, we said two layers above, two layers down. So the stratum basale is still down. Okay, so it's suprabasilar blister and acantholysis occur. Khas, we explained all of this, and it's due to IgG antibody against desmosomes or specifically desmoclein. So pemphigus vulgaris is blistering disorder due to IgG antibody against desmosomes or specifically desmoclein. It leads to acantholysis. Okay? Grossly, it's thin blister that easily rupture and causes erosions, so it's painful. It is Nikolsky sign positive and it affects the oral cavity. Why? Because you remember that you have erosion in your mouth one day. يعني. Histology wise, acantholysis, and if we did something called immunofluorescence, yani we see where are the IgG antibody, we will see them all over the place. Okay? It's called fishnet appearance. I will show you that later on. Now, in pemphigus vulgaris, we said that it causes acantholysis that separate the layers, and the stratum basale will still stay be down. Some stratum spongiosum will be up, some will be not, and so on. Now, one subtype of pemphigus vulgaris is pemphigus foliaceus. Okay, in pemphigus foliaceus, it will separate the layers. However, we will have stratum spongiosum all down and stratum bisalis all down, and stratum granulosum and stratum corneum are all up, not mixed. No, in pemphigus foliaceus, we will have autoimmune antibody against desmosomes that cause complete separation of stratum granulosum from stratum spongiosum. So we will have two layers above, which is the stratum spongiosum and stratum corneum, and two layers down, which is stratum spongiosum and stratum basale. So in pemphigus foliaceus, it's same to pemphigus vulgaris. Everything is the same. However, it causes. I need this to go. Okay. It causes subgranulosa acantholysis. So acantholysis under the stratum granulosum. Okay. So last time in pemphigus foliaceus, it's the same as pemphigus vulgaris. However, the separation will be under the stratum granulosum. Okay. That's it. This is a very common question. They put it once in OSPE and they put both options together. You need to put foliaceus because it's specifically under the stratum granulosum. Another disease is bullous pemphigoid. I need to say. We can see the picture. Okay, another disease is bullous pemphigoid. Bullous pemphigoid, it's a bullous, okay, like this one. It's caused due to autoimmune antibody against hemidesmosomes. If you have autoimmune antibody against hemidesmosome, you will have a blister that separates the epidermis from dermis. So as you can see here, there is no stratum basalis anymore. The stratum basalis is here. So it separates the whole epidermis from dermis, okay? And so we will have a very thick blister like this one that no matter how much you pop it, it will not pop. Okay? So it's Nikolsky sign negative. Okay? So in bullous pemphigoid, we have autoimmune antibody against hemidesmosome that causes complete separation of dermis from epidermis, causing formation of thick blisters that doesn't rupture, which is Nikolsky sign negative, and it doesn't affect the oral cavity. Have you ever in your life had a very big mass inside your mouth that doesn't pop? No, that never happened. That's why bullous pemphigoid doesn't affect the oral cavity. So in pemphigus vulgaris, it causes erosions, okay? And definitely you had one day an erosion inside your mouth, so that's pemphigus vulgaris affecting the oral cavity. However, in bullous pemphigoid, cause a very thick blister that doesn't rupture. Have you ever had that in your mouth? No way. So bullous pemphigoid doesn't affect the oral cavity. In histology, it's infrabasilar blister. Why it's infrabasilar? Because the blister is under the stratum basale because it's dissociated the both layers, right? So the blister is under the stratum basale because it caused separation of dermis from epidermis, and it's due to IgG antibody against hemidesmosome. If we did immunofluorescence to detect where the autoantibody will be, the IgG antibody, it will have linear pattern. It will follow the basement membrane. Let me show you this. So this is immunofluorescence, okay? It's a color that shows the IgG antibody. The shiny green lines are the IgG antibody. In pemphigus vulgaris, the IgG antibody will be throughout all the dermis. The epidermis, destroying the desmosomes. So they will have fishnet-like appearance, okay? Like this one. However, in bullous pemphigoid, the IgG antibody will be on all the basement membrane because it's destroying the hemidesmosomes that connect the dermis and the epidermis, okay? Sorry, the dermis and the epidermis. So it will be linear. So if you have immunofluorescence that is linear, that's bullous pemphigoid. If you have fishnet-like appearance, that's pemphigus vulgaris. Another disease that causes blistering is dermatitis herpetiformis. I don't want you to know much about this disease. It's related to celiac disease, okay? It's not caused by IgG antibodies. However, it's caused by IgA antibodies, and that's very common in celiac. I hope you know celiac by now. Celiac is autoimmune disease against gluten, okay? So these people can't eat gluten, and if they did, they will have IgA antibody attacking their body. Okay, so in dermatitis herpetiformis, we will have IgA antibody attacking the dermal papillae. So normally we have the dermal papillae, and it's the epidermis attached to it. The IgA will be only here and separating the dermis from the epidermis, however, only at the dermal papillae. So as you can see here, it's still connected. The separation only occur at the dermal papillae. So in dermatitis herpetiformis, we have IgA antibody that accumulates at the dermal papillae and cause dissociation of dermis from epidermis, only at the dermal papillae. Okay? Uh, it causes these lesions that looks like herpes, and when you scrub them, you will bleed immediately. So, dermatitis herpetiformis, two information: IgA antibody on dermal papillae, and lesions that when you scrub them, you will bleed immediately. Okay, this is very likely to not come at in OSPE, but it's very common at MCQ. So please know that if someone have a lesion and they scrub it and they bleed immediately, that's dermatitis herpetiformis. Final blistering disorder is epidermolysis bullosa. Okay, this is an inherited disease. The other diseases are autoimmune diseases due to autoimmune antibody destroying the desmosomes and hemidesmosomes. However, in epidermolysis bullosa, they have inherited weakness of desmosomes and hemidesmosomes and keratin itself. So keratinocytes normally develop to contact each other through desmosomes and hemidesmosomes. In epidermolysis bullosa, it's an inherited disorder that causes weakness of keratin and desmosome and hemidesmosomes that causes thin bullous, thick bullous, weak skin, everything. Okay, so it's very vicious and severe disease, as you can see here. And it's inherited disorder due to impaired keratin and adhesion desmosomes, hemidesmosomes, and it leads to multiple blisters, erythema, erosions. It's very vicious disease. All I need you to know is two things: the pictures of it and that it's inherited disorder. Okay, now we finished the blistering disorder. Now we have paniculitis. Normally, the epidermis, under it there is dermis, and under this whole thing is called skin. Under the skin, we have subcutaneous fat. Subcutaneous mean under the skin. Fat is fat, okay? So, paniculitis is inflammation of this subcutaneous fat, okay? So, in paniculitis diseases, we have inflammation of subcutaneous fat. We have two types: erythema nodosum and erythema induratum. In erythema nodosum, this is the epidermis, this is the dermis, and here we have fat, okay? The fat is divided by septum. In erythema nodosum, we have inflammation of the septum itself. The lobules here are not affected. It's just the septum that is inflamed. So in erythema nodosum, it's inflammation of the septal fat, okay? Here we have the septum. The septum itself is inflamed, However, the lobules are normal. Okay? So in erythema nodosum, we have inflammation of the septal fat. It doesn't affect the lobules and it's not associated with vasculitis and doesn't cause ulceration. It just causes lesions. Okay? So grossly, it's non-ulcerative lesion. It's mainly on the anterior side of the leg. And histopathology shows septal inflammation of the subcutaneous fat. So erythema nodosum, inflammation of the septal fat. It doesn't affect the lobules, not related to vasculitis, and has no ulceration. It usually affects the anterior side of the leg. This is very important. And it's non-ulcerative. On the other hand, we have erythema induratum. Erythema induratum is inflammation of the lobular fat. Okay, so normally we have the septum and here the lobules. In erythema nodosum, it's just the septums. In induratum, the lobules are inflamed. So as you can see here, we can't tell where is the septum and where is the lobules. It's just like scattered everywhere. So we have inflammation of the whole lobules, okay? That causes inflammation of the lobules, it causes masses and causes ulceration and is associated with vasculitis. So erythema nodosum, not associated with lobules, not associated with vasculitis, and not ulcerative. In erythema induratum, it is associated with lobules inflammation, it is associated with vasculitis, and it is ulcerative. Okay, so grossly, it's ulcerative region, mostly at the posterior aspect of the leg. That's very important. It was a question. Erythema induratum is associated with which location? And you need to choose posterior side of the leg. We finished the paniculitis. I just want you to know two important things about them. Erythema nodosum is associated with septal inflammation of subcutaneous fat and its anterior side of the leg. On the other hand, erythema induratum, it's the posterior side of the leg and it's associated with everything, vasculitis, ulceration, and everything, and it's associated with lobular inflammation. I hope that is clear. Now we just have tumors of the skin and خلاص. We finish the derma. We still have micro after that and خلاص. Okay? So normally the skin is made of epidermis and dermis. We said that. Epidermis is made of 4 layers. Basal cell layers and 3 other layers. Okay? Epithelial tumors are proliferation of these epidermis layer. Okay? Not dermis, epidermis layer. It's either the basal cell layer or the other 3 layer. Okay? Okay. First, we have seborrheic keratosis. Seborrheic keratosis is benign. Okay, it's benign proliferation of epidermis lead to formation of coin-like stuck on plaque. Okay, so in seborrheic keratosis, we have benign proliferation of keratinocytes in the epidermis that causes this coin-like lesion. Okay. In histology, we have keratinocytes, pseudocysts. It's full of keratin inside the epidermis, which is this keratosis, and this keratinocytes look like a pseudocyst. Okay. If we have a lot of seborrheic keratosis, it's called lizard trillet sign, and it's associated with GI cancer. That's all I want you to know from seborrheic keratosis. Seborrheic keratosis is benign proliferation of epidermis, causes coin-like stuck on plaque appearance, which is like coin-like lesion. And in histology, it's keratinocytes pseudocyst. By the way, this picture, yani, every year it comes. So memorize it. Seborrheic keratosis. Second one is acanthosis nigricans. Acanthosis nigricans, from the name, it's acanthosis. And acanthosis is hyperplasia of the whole epidermal layer. Okay? Acanthosis nigricans is epidermal keratinocytes hyperplasia, like hyperplasia of the whole thing, with darkening of the skin. The skin becomes dark. Okay, it's commonly occur at the armpit and the wrist and the neck. And in histology, we have velvety appearance, which is papillomatosis and acanthosis. As you can see here, the papillae are very like large, and we also have acanthosis. Okay, it is associated with type 2 diabetes mellitus, which is insulin resistance. So acanthosis nigricans, from the name. Acanthosis, it's causing epidermal hyperplasia, and nigricans, it's causing يعني blacking of the skin. It's commonly at the armpit, neck, and wrist. Histology-wise, it has velvety appearance, which is papillomatosis and acanthosis. And finally, it's associated with insulin resistance. Third thing we have is fibroepithelial polyp. I just want you to know what is a polyp. Polyp is a fibromuscular core, like core full of stroma surrounded by epithelium. That's polyp. In all diseases, polyp is fibrovascular core, core full of stroma, blood vessels, lymphocytes, surrounded by epithelium. So fibroepithelial polyp, it's a polyp on the skin. It's well demarcated and it's made of fibrovascular core with epithelial surface. That's important in OSPE. Okay. Then we have actinic keratosis. Actinic keratosis is benign, okay? However, it's dysplastic and it may become cancerous. So what is actinic keratosis? It's dysplastic growth. In seborrheic keratosis, it is benign. In actinic keratosis, it is benign, but it's dysplastic that may become malignant. So in actinic keratosis, it's dysplastic growth of squamous cell, which is epidermis, lead to formation of scaly erythematous papule on sun-exposed area. So someone who is working يعني in workstation areas exposed to the sun all the time, they will have dysplasia of the skin, causing dysplastic growth of squamous cell, causing these lesions, which has sandpaper texture. So that's a buzzword for actinic keratosis. If the question said sandpaper texture, actinic keratosis. Okay? In histology, dysplastic growth of squamous cell, and it may become squamous cell carcinoma later on. So actinic keratosis, it is benign, but it is dysplastic growth of squamous cell on sun-exposed area, cause formation of this sandpaper-like texture of a lesion, and it's a precursor of squamous cell carcinoma. Now we have squamous cell carcinoma. Squamous cell carcinoma is neoplastic proliferation of the squamous cell of the epidermis. However, it's all the layers except the stratum basale. Stratum basale, if it has malignancy, it's another disease. Okay? So, squamous cell carcinoma is neoplastic proliferation of the epidermis except the stratum basale. Okay? Lesion-wise, it is causing elevated nodule with central ulceration and sclerosis. As you can see here, we have a lesion with ulceration and sclerosis. Histology-wise, it's like any squamous cell carcinoma. It has keratin pearls. And location, it's in the face and lower lip. Okay? Remember, face and lower lip. Squamous cell carcinoma, face and lower lip. So, squamous cell carcinoma, neoplastic proliferation of squamous cell, except the stratum basale. Now, why it happens? Because of UV light DNA damage. So when we get exposed to the sun a lot, we will have like UV lights damaging our skin. Also in albinism, because they don't have melanocytes, so it doesn't protect the skin from the UV light. And xeroderma pigmentosum, that's a disease. If you know it, you know it. If you don't know it, that's fine. Just know it causes squamous cell carcinoma. Grossly elevated nodule with central ulceration and sclerosis. Histo nodules of squamous cell and keratin pearls. Location, face, and lower lip. Now, we have a variation of squamous cell carcinoma called keratocanthoma. Keratocanthoma is squamous cell carcinoma that rapidly progress, like suddenly you have squamous cell carcinoma and rapidly gone, okay? So you suddenly have squamous cell carcinoma and suddenly it disappears. That's keratocanthoma. If we looked at the appearance of it, it's like a volcano, okay? It's like, you can see it, it's like a volcano. So that's keratocanthoma, squamous cell carcinoma that develops rapidly and regresses rapidly on its own. We don't have any treatment, just go and comes and go, okay? It has volcano-like shape. It's a variation of squamous cell carcinoma. Finally, we have basal cell carcinoma. It's neoplastic proliferation of basal cell layer. So epidermis is made of 4 layers. If the 3 layer above have malignancy, that's squamous cell carcinoma. If the stratum basale have cancer, that's basal cell carcinoma. So basal cell carcinoma is neoplastic proliferation of the stratum basale. It will cause elevated nodule with central ulceration. However, it doesn't have keratin, the dead keratin, because it's just the basal cell layer. So it will have telangiectasia, which is blood vessels appearing, because under this basal cell layer, we have blood vessels of the dermis. So we will have them appearing here. So in squamous cell carcinoma, we have sclerosis. In basal cell carcinoma, we have blood vessels, which is telangiectasia. Okay? In histology, we have nodules of basaloid cells. Basaloid are the basal cells. So we have nodule of basal cells, or called basaloid cells, and location is face and upper lip. So squamous cell carcinoma, which is above, the 3 layer above, causes lower lip. And basal cell carcinoma, which is downward, causes upper lip cancer. Okay? So basal cell carcinoma, neoplastic perforation of basal cells. Etiology, same as squamous cell carcinoma. Risk factors is same as squamous cell carcinoma, UV light stuff. And grossly, it's an elevated nodule with central ulceration and telangiectasia, which is blood vessels appearing on it. Histology, nodule of basal cells or basaloid cells. Location is the downward cells, so it affects the upper lips. We finished the epithelial cell tumor. Now we have disorders of melanocytes. So normally we have the epidermis, and in the epidermis, next to the stratum basale, we have melanocytes, which is melanin secreting cells. They are cells important for our pigmentation. Now, if we have benign proliferation of them, يعني they are developing benignly, not dysplastically, not malignant, nothing, just benignly proliferating. It will most likely go like this, radial growth, which is called lentiges, okay? If we have benign proliferation of them, we have something called nevus or mole, اللي هي الشام, okay? We'll have mole, which is like hyperpigmentation in our skin, and that's nevus or mole. Okay, so nevus or mole is benign proliferation of melanocytes. It can be congenital or acquired. I can be born with this mole. I have many moles that are born with, and it can be acquired. That maybe I burn my skin or due to sun exposure, I develop this thing. Okay, so it can be congenital, which is at birth. And one sign that it's congenital that this nevus has hair in it. So we have this nevus and the hair is coming out of it. That's congenital and that's benign. Okay? So congenital mole are moles that have hair growing out of them. Okay? Or it might be acquired. If it's acquired, it begin at the dermal epidermal junction. Here we will have a mole. Okay? Then when we grow up, it will go down. Okay, so it will be in the upper dermis. And later on, when we are like elderly, it will disappear from above and it will stay down. Okay, so nevus is benign proliferation of melanocytes. It can be congenital at birth, it will have hair out of it, or it can be acquired, which starts at the dermal epidermal junction. Then when we grow up, it goes down. And later on, it disappears from above. It doesn't go very deeply, it's just superficial dermis, so it's still benign. Now, grossly, it's very important. It's very nice and not weirdly looking. So it's a flat macule, as like this, or it's a raised papule, like this. Okay? So it's either flat because it's still in the dermal-epidermal junction, or it might be raised because the melanocytes went down, so it pushed the cells above them and causes this raised appearance. So it can be flat. So it's on the dermal-epidermal junction, or it can be raised because it went down and pushed everything above. It is symmetrical, it is regular borders, so it looks like a circle. It's evenly distributed color, so it's يعني dark in the center and lighter outside, and it's small, less than 66 millimeter. It may become dysplastic and become melanoma, which is cancer. Yes, it can. Now there are multiple types of this nevus. So this one is congenital nevus. It has hair out of it, but I know this is not the most clear picture, but it may come in the exam, so memorize this picture. It's congenital nevus. It might be blue. Usually the nevus is brown, but it might secrete blue color, so this is blue nevus. It might be raised, so it's intradermal nevus, like this one, and it might have some whitish circle around it, that's hollow nevus. Memorize these because it may come in the exam. Now I want you to differentiate intradermal nevus from the compound nevus. Intradermal nevus is just the nevus being barely on the superficial dermis and it goes a little bit raised. However, compound nevus, it goes a lot down and it causes like very big raised appearance. Okay, so if it's like very big, that's compound nevus. If it's يعني flat barely raising, that's intradermal nevus. Inshallah, they don't bring both, but خلاص memorize the picture. Usually this one is the one that comes in the exam. Now the nevus might become dysplastic. If it becomes dysplastic, it will be weird looking. So nevus with dysplastic features, is what we call dysplastic nevus. Okay, it's still not malignant. It's still confined to the membrane. يعني it's barely in the superficial dermis or epidermis, but it has some dysplastic features. That's dysplastic nevus. Usually it doesn't come in the exam. And now, if this nevus become cancer, it becomes melanoma. Melanoma is neoplastic proliferation of melanocytes. Okay, so the melanocytes, usually, as we said, it goes radially, but if it went down and it's very dysplastic, that's melanoma. Okay? What does that happen? Same as skin cancer. UV sunlight and then prolonged UV light exposure, albinism, xeroderma pigmentosum, and these things. Okay? Now, melanoma is very dysplastic, very ill-looking, very ugly, and it has the ABCD features. A is asymmetrical, as you can see here. It's يعني we can't divide it to two sides because it's very like look here. It's very weird looking. It's asymmetrical. B is irregular borders. It has weird borders. C is color is not uniform. Here it's dark. Here it's white. Here it's يعني very light. D is diameter, which is bigger than 6 millimeter. Okay? So melanoma is neoplastic proliferation of melanocytes that goes down. It has the APCD feature. A is asymmetry, B irregular border, C is color is not uniform, and D is diameter more than 6 millimeter. Okay? In histology, it's dysplastic melanocytes that are all over the place. As you can see here, melanocytes all over the place. Melanocytes all over the place. Dermis, epidermis, deep dermis, everywhere. Okay? It has two types of growth. Radial growth, which is horizontal, and that has good prognosis, or vertical, which goes very down deep, and that's bad prognosis. Finally, the melanocytes come from neural crystal. If you know what's that in embryo, we have like different type of embryological derivatives, and one of them is neural crystals. And neural crystals stain for S100 stain. So here we stain it with S100 stain and stain positive. That's all I want you to know from melanoma. It's neoplastic growth of melanocytes. Can go radially, vertically, but mainly vertically. That's why it's malignant. It has the APCD features. Histopathology is dysplastic melanocytes all over the place. It stains S100 positive, and that's it. We finished all the derma stuff. Now we just have Derma Micro, which is inshallah easy. All right, last part, which is Derma Micro. This part has so many pictures, so many things, but only the info. I just want you to know the info. Like this picture is this disease. This picture is that disease because it's very random. Okay, they may get anything from your lecture. I tried to include most of the things, but please cover your lectures for your MCQ also. So first we will start with explaining what is a pilosebaceous unit. Normally this is your skin, epidermis, dermis, whatever. This is a hair follicle. We have something called pilosebaceous unit. It contains three things. First, the hair follicle itself. Secondly, the muscle around the hair follicle, okay? That the one that contracts, okay? And finally, the sebaceous gland. So pilosebaceous unit contains three things. Hair follicle, the erector pili muscle, and the sebaceous gland. It doesn't include anything else. Sweat glands are not included, eccrine gland are not included. Just the three things. Hair follicle, erector pili muscle, and sebaceous gland. That's the pilosebaceous unit. Okay? Now, the sweat gland is not part of the unit. However, one important info I want you to know about it, it's the thermoregulator. Okay? So it's the one that regulates the temperature in your body. So when it's very hot, very cold, it secretes the secretions of like the sweat gland, and it's help with thermoregulation. Okay? That's the only two things I want you to know from this slide. Now we have acne, which is حب الشباب. Okay? Acne is an inflammation in the hair follicle. Normally, we have the hair follicle, the sebaceous gland, and the muscle. Okay? The sebaceous gland secretes its secretions and goes up. Okay? If for any reason we have an obstruction here that causes the sebaceous gland secretion to accumulate, or we have increased secretion of the sebaceous gland that causes also accumulation of the sebaceous gland secretion, it will cause bacteria to grow and causes inflammation of the hair follicle, causing acne. So, what's the pathophysiology of acne? It's due to obstruction of the hair follicle. So there's the hair follicle and we have obstruction due to keratinization, or we have high sebaceous gland secretion, okay, that cause the sebaceous gland secretions to accumulate, and then P acne or C acne will grow and causes inflammation. So acne is inflammation of the hair follicle caused by two bacteria. The first one is Cutibacterium acne, and the second one is Propionibacterium acne. Okay? So acne is caused by these two bacteria due to obstruction of the hair follicle or increased secretion of the sebaceous gland. What causes this? What causes obstruction? Mostly tight clothing. So someone wearing a hat all the time, someone wearing tight jeans all the time, this will cause acne to develop on that area. What causes high secretion of sebaceous gland? Usually puberty or taking steroids. Like anything that increases testosterone will causes high sebaceous gland secretion and lead to acne. So I just want you to identify acne from the picture. And this is C acne and P acne picture. Okay? That's acne. Now we have impetigo. Acne was inflammation of the hair follicle. Impetigo is inflammation of the epidermis only. Okay? So this is the skin, this is epidermis, this is dermis, this is fat. Impetigo is inflammation of the epidermis only. This is a question that got asked twice. Impetigo affect which skin layer? You need to choose epidermis. Okay? So impetigo is superficial skin infection that affects epidermis only. It's due to either two bacteria, either Staph aureus or Strep pyrogens. Okay? Clinically, it causes erythematous macule that progress to pustules. So first start with macules, then it will become pustules. That has erogen and honey cream colored serum. Okay, so impetigo, superficial infection that affects the epidermis. Due to Staph aureus or Strep pyrogen, causes erythematous or pustules that cause inflammation in the face, usually in the face or in the back. Okay, impetigo is two type: pullus and non-pullus. Non-pullus is like this, erogens. Pullus is like this, there is a pulli. Okay, non-pullus is mostly due to Strep pyrogens. Pullus is mostly due to Staph aureus. I just want you to memorize these things about impetigo. Okay, now I want you also to identify Staph aureus. It's gram positives in cluster, and Strep pyrogen is gram positive in chain. Okay, okay. Now we have something called ecthema gangrenosum. Now in impetigo, we said it's either erogens or honey cream mustard, whatever color, like yellow. However, ecthema gangrenosum, it caused due to Pseudomonas, so the color will be green. So if you have an inflammation and infection of the skin and it looks green, that's Pseudomonas, that's ecthema gangrenosum. Okay, so you choose this agar. If they put this picture and cause which of the following bacteria that causes this? It's Pseudomonas, which is this agar. Now I also said that in the epidermis we have a fungi called Malassezia furfur. It grows normally on the skin and it's normal to be there to protect us from other things. And if it has an overgrowth, it will either cause seborrheic dermatitis, which is inflammation of the hair follicle, or it may cause pityriasis versicolor. Pityriasis versicolor is due to overgrowth of Malassezia furfur that cause light skin lesions. That's all I want you to know. You saw this picture with light skin lesion, that's Malassezia furfur, and that's pityriasis versicolor disease. Now, impetigo and ecthema gangrenosum and all of these diseases affect epidermis only. Okay, it doesn't affect the dermis. However, what if the infection reached the dermis? We will have either erysipelas or cellulitis. Okay, in erysipelas, it's an infection that affects superficial dermis. Okay, so if we have a bacteria that affects superficial dermis only, that's erysipelas. Okay, grossly, it is well demarcated. You can see that there are lines here that define the inflammation, okay? And it's mostly happened due to Strep pyrogens, then Staph aureus. So usually Strep pyrogens, if not, then Staph aureus. As you can see here, it's well demarcated. On the other hand, we have cellulitis. Cellulitis is infection of the deep dermis. So cellulitis, infection of the deep dermis. It causes diffuse inflammation. It's not well demarcated, as you can see here. It's just inflammation. It's usually due to Staph aureus more than Strep pyrogen. It's either Staph aureus or Strep pyrogen, but mostly Staph aureus. Why? Because Staph aureus have something called exfoliative toxin that causes يعني destruction of the skin that is not organized. That's why it's not well demarcated. It is way more severe than all of the other diseases that we have mentioned. So, if they brought a picture of impetigo, eczema gangrenosum, erysipelas, and cellulitis, and asked which of the following you should treat first, then it's cellulitis. Okay? So, for the final time, we may have infection of the epidermis only, and that's impetigo, eczema gangrenosum, and so on. We may have infection of the hair follicle, that's acne or seborrheic dermatitis. We may have inflammation of the superficial dermis, that's erysipelas, and we may have inflammation of the deep dermis, that's cellulitis, and it's the most severe. Now, other Staph aureus infections. Staph aureus usually live also on our skin and may cause infection. We have folliculitis, which is superficial inflammation of the hair follicle. So this is the hair follicle. If we have superficial inflammation of it, then that's folliculitis. And it's usually due to Staph aureus. Now, if this inflammation goes deep into the hair follicle, that's furuncle, which is deep infection of the hair follicle. And finally, if we have multiple hair follicles that are inflamed deeply, which is يعني multiple furuncles, that's carbuncle, which is cluster of furuncles. Now we also have an infection caused by Staph aureus, causing a disease called Staphylococcus scalded skin syndrome. Staph aureus go into the skin, release its exfoliative toxin, and causes scaldation of the skin, as you can see here. That's Staph aureus scalded skin syndrome. Just want to memorize the picture. It's caused due to Staph aureus. Oh, it goes. Wait. Yeah. So Staph aureus goes to the skin, causes this scaldation of the skin, and that's occurred due to the exfoliative skin toxin. Finally, we have erythema marginatum, which is erythema in the skin. I just want to memorize the picture, and it's caused due to strep pyrogens, and this is the occur of it, and it's part of rheumatic fever. I'm not sure if you covered rheumatic fever or not yet. It's يعني a disease that have joint manifestation, heart manifestation, and skin manifestation. It's called erythema marginatum. The question won't come as the picture only. It will say a person has erythema marginatum. Which of the following bacteria causes it? And you choose this agar, which is strep pyrogens. Then we have Rocky Mountain spotted fever. It is fever with petechia, which is يعني these dotted lines on the skin. It's caused due to rickettsia. So if someone has fever and he have these lesions, which is dotted red dots, then it's Rocky Mountain fever due to rickettsia. It's due to a tick and it lives inside the macrophages. Now, viral derma stuff. First, we have the cold sores. It appears on the skin, on the lips, and it's due to HSV1. We have also chickenpox, which is the judari. It's due to varicella zoster virus. It usually occur in children, and when it occurs, it lays dormant in the skin, in the neurons, sorry. And in older people, it will come back and cause shingles or herpes zoster, which is also caused due to varicella zoster virus. It follows the neurons, so يعني there is here the spinal cord, here are the neurons, and it follows the neurons. Okay, so if we have cold sores, that's HSV1. If we have in children, we have chickenpox, that's varicella. And in older people, if we have erythema that following neurons, that's herpes zoster or shingles, which is varicella zoster virus. We also have this dome-shaped lesions. It's called molluscum contagiosum, and it's caused due to pox virus. So if you just saw this picture, choose pox virus. It's molluscum contagiosum. And if the child have a slap cheek appearance, yani his cheeks are very red, even with the neck, that's parvovirus B19. Just memorize the picture with parvovirus slap cheek appearance. Also, if someone have this cheeks inflammation and also have cough, coryza, which is runny nose, conjunctivitis, and the slap cheek appearance, these people having measles. So measles is a viral infection that causes the 4Cs disease, which is cough, coryza, conjunctivitis, and slap cheeks appearance. And it has a vaccine, which is MMR. They brought you a question, which of the following will have a vaccine? And they bring you molluscum contagiosum, parvovirus, and measles. You choose measles. So the slap cheek appearance is similar to malarial rash, which is an SLE, or in parvovirus, or in measles if it comes with cough, coryza, and conjunctivitis. Now we have something called Kaposi sarcoma. Please, guys, this is very important. I got it wrong in my exam, okay? Normally, we have the skin, and under the skin, there are blood vessels, okay? Kaposi sarcoma is neoplastic proliferation of these blood vessels. So we have cancer of the blood vessels under the skin. Now, why would a blood vessel will have cancer? Is due to an infection, due a virus called herpes, human herpes virus 8. Okay, so Kaposi sarcoma is neoplastic proliferation of blood vessels under the skin due to infection of human herpes virus number 8 in immunocompromised patient. The patient must be immunocompromised, have low immunity. So human herpes virus 8 can cause the infection. So, who are immunocompromised patients, HIV, transplant people, and so on. So, Kaposi sarcoma, neoplastic proliferation of blood vessels due to human herpes 8 in immunocompromised patients. How will they appear? Like these red plaques, macules, nodules. This is the picture come in my exam. And histology, it's spindle cell proliferation. Yani the blood vessels will proliferate like spindle cells. Memorize all these info. All of them were in the question. Kaposi sarcoma, neoplastic proliferation of blood vessels due to human herpes virus 8, HIV, and transplant patients. Grossly, red plaques, macules, nodules. Histology, spindle cell proliferation. Now, SLE rash. SLE can cause malar rash. It can cause discoid rash, which is yani, sudden rash in a specific place, well demarcated, and it may cause chest rash. The question was like this. SLE will affect which of the following parts of the body? The answer is face and chest. SLE only affect face and chest in terms of rash, okay? So SLE causes malar rash, discoid rash, and chest rash. Now we have dermatophytes, which are fungi, okay? These fungi doesn't live, but it grows on our skin, okay? Causes tinea disease. So if we have dermatophyte that grows in our skin that causes erythema, that's tinea disease. And it depends on the place. If it's on the head, it's tinea capitis. If it's in the body, arms, legs, abdomen, tinea corporis. If it's in the genital area, here, then it's tinea cruris. And if it's between the legs, it's tinea pedis. And if it's in the nail itself, then it's tinea unguium. Okay? Please don't mix this with the oncolysis and the other nail pitting stuff. This is onychomycosis, which is fungi on the nail, and it's due to tinea ongonium. Then we have leishmania. Leishmania is a parasite that affects our body, can affect the blood vessels, the liver, and it can affect the skin and causes these lesions. And the disease called leishmaniasis. Okay, I just want you to know three things. The picture of leishmania, this picture is the picture that they bring for leishmania, and the infective stage of the parasite of leishmania is amastigotes, which is this one. And finally, the vector for leishmania is the sandfly. This is the picture of it. That's all I want you to know of leishmania. Then we have scabies. Scabies is الجرب. Okay, it's when you see someone with a very bad hygiene just scrubbing their body and their head. That's due to scabies. Scabies is a severe pruritic rash. It's a rash that's very pruritic. They just need to scrub it all the time with erythematous papules and vesicles due to like a lot of scrubbing. Okay, why does scabies happen? Due to scabies mite. Okay, scabies is a mite that affect the epidermis and causes this disease. Clinically, they will have severe pruritic rash on the flexor surface, like here, okay, and interdigital space here. Usually, the buzzword in the question that someone lives in his college with a very bad hygiene suddenly have severe pruritic rash interdigitally. Okay, so they just scrub like this, and that's scabies. One important info that scabies affect the stratum corneum mainly. This is the epidermis, scabies, and the mite itself, and its feces are on stratum corneum only. Okay, that's scabies. Now we will solve the previous batch question because we finished everything. I will just solve the previous batch question. If you are interested, continue. If you're not, because you can go to the end of the video, see the feedback. Please like send your feedback regarding this session and خلاص. All right, guys, now we will solve the previous batch questions, all of them, till batch 8. And everything here in the previous batch questions, I included like in my slides, except one question about a ligament, because I believe it will never come. It's in the 8th batch. So let's start. Which of the following is the vector of leishmania? Okay, leishmania is caused due to sandfly, so that's the vector of leishmania. Just a sec. I think there is a problem. Yes. Okay, so the vector of leishmania is the sandfly. Which of the following disease is treated by doxycycline and amoxicillin? We said one disease is treated in doxycycline in adults and amoxicillin in children, which is Lyme disease. Which organism is likely cause this? This is cellulitis. Most likely Staph aureus. If not, strep pyrogens. So the answer is strep pyrogens because Staph aureus is not in the choices. Which organism is most likely involved? This is the Bullseye legion. This is Lyme disease. So it's Borrelia burgdorferi, whatever the name is. Which of the following is caused by this bacteria? This bacteria is green, so it's Pseudomonas, right? So which of the following caused by Pseudomonas? This is the green legion, which is Ecthema gangrenosum. Now, which of the following caused this inguinal legion? This is a dermatophyte. It's Tinea cruris. So which of the following is the fungi? This is the fungi. What's the diagnosis of this? If we looked at this disease, we will have the picture frame and we will have mixed osteolytic osteoplastic lesions, and this is Paget disease. What's the diagnosis of this? This is not an X-ray, this is an MRI. And in an MRI, we look to this. That's how bones should be. It should be very white in MRI. So if we see this, that's not thickening or picture frame. That's how the normal bone should be. And inside it, the bone is very thin and low density. So this is osteoporosis. Also, the biconcave shaped, this shape, is a feature of osteoporosis. What's the diagnosis of this? This is a tendon that became calcified, so it's calcific tendinitis. What's the diagnosis of this? We said if a child have an osteonecrosis, then it is the leg calf paresis disease. What's the diagnosis of this? Here we have the femur and we have the gluteus tendon attached to it, and it's inflamed and interrupted, so it's gluteus medius tendinopathy. Now we said this fracture, avulsion fracture or buccal fracture in the knee of a child is not it's not accidental. It's due to child abuse. So what's the diagnosis? Non-accidental injury or child abuse. It can come in either form. Now, what's the diagnosis here? Now, I want you to focus that you may think this is the lesion. No, no. Look here. We have this avulsion fracture of the we have a avulsion fracture of a finger at the tip, which is malate finger. Okay, what's the diagnosis? We have the light bulb sign. So it is posterior, light bulb sign, which is posterior dislocation. What's the diagnosis? We said if we have melanoma or nevus, that's the very like raised, like a dome shape, that's compound nevus. Here, what's the disease? We said, look at the question. Someone who ate egg and suddenly have anaphylactic reaction. So this is urticaria or hives. Urticaria or hives are mast cell dependent IgE urticaria. Okay? Yeah, I think they repeated. Yeah, here it says independent. So please be careful that you choose the dependent one. Okay? It's mast cell dependent IgE urticaria. What's this? We said if we have a lesion like herpes, then it's herpetitis dermatiformis. It's related to celiac disease, which is related to IgA. What's this? We have a lesion, not ulcerative, not related to vasculitis on the anterior aspect of the leg. That's erythema nodosum. What's this? We said if we have irregular lamina of the bone and irregular osteoid, that's Paget disease. Then what's this? We have a lesion at the metaphysis that looks blue. Then it's chondrosarcoma, and it's related to chondroblast. Also, you can use this as a hint, multiple nuclei in lacuna. It's like chondroblasts in lacuna. 20-year-old female, bilateral involvement. And if it's bilateral, then it's rheumatoid arthritis, not osteoarthritis. And the pain is worsened in the morning. So when she wakes up and the autoantibodies are in the joint, there we have the pain. Then that's rheumatoid arthritis. And if you looked at the picture, it affects PIP, but it spares DIP. DIP is not affected. So that's definitely rheumatoid arthritis. What's this? That's erythema multiforme, the targetoid lesion. 14-year-old child, mass on the diaphysis, CD19, and we have a very ugly looking lesion. That's Ewing sarcoma, the EU disease. It is a child, which is EU. It's diaphysis, which is the lower part of the bone. So the upper part hates the lower part. That's why it's lower part. That's why it's EU. And it has an ugly looking, that's Ewing sarcoma. Finally, which of the following is the most common site of osteosarcoma? We said it's the knee, which is D. Okay, final question. Someone who came with left knee pain, denies history of trauma or infection. On examination, left knee pain is swollen. So it's monoarthritis. It's either septic arthritis or gout or pseudogout. Okay. Uh, the gram stain is negative, blood culture is negative, so it's not pseudogout. It's not septic arthritis. It's either gout or pseudogout. When we look at the picture, I read in the question that it should be rhomboid in the exam, so it is calcium pyrophosphate. Okay, so it's pseudogout. Depends on the picture, okay? They said the picture were bad. But if it's needle, then it's gout. If it's rhomboid, it's calcium pyrophosphate, which is pseudogout. Okay, we finished MSQ of this batch. Let's go to the OSPE. Sorry, we finished OSPE of this batch. Let's go to the OSPE of the 14th batch, which is my batch. And unfortunately, guys, we were a very bad batch in terms of exam committee. I don't know why. So we didn't collect anything. It's just so Fush. Which bone is injured? We said Fush is Colles fracture, which is distal radius. Picture of basal cell carcinoma. Just remember that it is a nodule with telangiectasia. Picture of squamous cell carcinoma. It's a nodule raised with keratosis in the middle. Herpes, human herpes 8 virus picture. It's the one with red plaques, nodules, and whatever. It's Kaposi sarcoma. Picture with celiac disease. You need to choose dermatitis herpetiformis. Is there going to be a picture? بصراحة I don't remember this question. Pooping sound, ACL. It was a picture of ACL. Osteoarthritis picture, gout picture. I remember the gout picture. It was a finger with like very big tophi and inflammation and whatever. We have the picture in my slides, the same picture. Picture of lunate dislocation, I put it in my slides. KP's picture, I put it in my slides. Picture about pemphigus vulgaris, I put it in my slides. Parvovirus, the slap cheek, I put it in my slides. Person rickettsia, I put it in my slides. Picture given about Staphylococcus calcin, I put it in my slides. Waxing wing psoriasis, also put in my slides. Now 13th batch OSPE. Without, not without, you need to read it, but for the sake of time, this someone has tophi and inflammation. This is gout, but you also need to read the whole thing. If it's interarticular, so it's like calcium accumulation between the joints, that's pseudogout. If it's intra-articular inside the joint and the bone, it causes inflammation and swelling, that's definitely gout. What's this? This is an abscess, so it's Brody's abscess related to osteomyelitis. Uh, let's read the question. Hand waxing and waning, that's psoriasis. Like if you read the whole thing, it's psoriasis, and this thing is psoriasis. It also affects the nails, causing oncolysis and nail pitting, so it's also damaged the nails. Pharma question of OSPE, I didn't cover them, but this one is easy. This is someone having septic arthritis, and what drug you will give. It is a beta-lactam, and beta-lactams damage the membrane. So it's a C. What's this picture? We said seborrheic keratosis. This is D. Please read the question in the exam. What's this? It's erythema multiforme, and it's the interphase dermatitis. So it is erythema multiforme. What's this? This is the fibrovascular polyp or fibroepithelial polyp. What's this? We said raised nodule with telangiectasia, and this is basiloid nodules. This is basal cell carcinoma. Which of the following layers is affected by impetigo? Impetigo affect the epidermis. Now I want you to focus. This one, oh, wait. Yeah, this one is the hair follicle. Oh my God. This one, this will happen again. Okay, this one is the hair follicle. A refers to the hair follicle. Hair follicle is like acne and stuff. But impetigo affects the epidermis. So how do you know? Let's zoom out. How do you know that this is the epidermis and this dermis? We said dermis is full of blood vessels and glands and lymphocytes. However, epidermis is empty. So B is the epidermis. Please, A is the hair follicle. B is the epidermis. So which of the following layers is affected by impetigo? B, epidermis. This someone is having septic arthritis. What's the most common site of transmission? We said septic arthritis, hematogenous spread. So it is the blood vessel, which is B. Okay, we said septic arthritis and osteomyelitis, hematogenous spread. This picture, Malassezia 44. Okay, here we have separation of the skin layer. We have a blister. The location of the bullae is in the picture. Which of the following is the disease? We have the picture, and as you can see, this is the dermis. This is the stratum basale. This is the stratum spongiosum. And here we have two layers, the stratum corneum and stratum granulosum. Only two layers, as you can see. It's two different colors, two layers. So it's pemphigus foliaceus. If there is no pemphigus foliaceus in the choices, put vulgaris. So if in the exam you have two layers down, two layers above, that's pemphigus foliaceus. If it's mixed, that's vulgaris. There's also a pharma question. It's rheumatoid arthritis, and the treatment is DMARDs, and one of the DMARDs is leflunomide, and leflunomide inhibit what's called formation of orotate from dehydroorotate. So you need to memorize this. Okay, you need to memorize the mechanism of action of DMARDs. I didn't cover pharma. Again, what's this? This is giant cell tumor. It's the soup bubble sign, so it's giant cell tumor. Soup bubble sign, it's in the question. What's this? This is acne. Acne is due to bacteria. What is the bacteria? B acne, C acne. All right, what's this? If we zoomed in, oh my God, what's going on? Okay, if we zoomed in, it's the pencil cup appearance. Pencil in a cup. What's that? Psoriasis. Psoriatic arthritis. Okay, this is scabies. Scabies affect which layer? We said stratum corneum. We said scabies affects the stratum corneum, and it lays its feces in stratum corneum, and the mite itself is in stratum corneum. So scabies, stratum corneum. Yep, corneum. This bullseye lesion, Lyme disease. Lyme disease. Okay. Now OSPE of this patch. Yeah, this one I'm sure it won't come. I think Aslan it's not in your slides. It wasn't even in my slides, nor the slides of the batch beforehand. What's this? This is HSV. Also this one Aslan I didn't include because I don't think this is correct. From my step study, I don't think this is correct. It's not Aromanus hydrophilus. It's something else. It's Mycoplasma merinia, which is affect the fishermen and like people who are like exposed to the fish and the water and stuff. So I don't think this is correct Aslan. It's Mycoplasma merinia, but I don't think Aslan it's in your slide. Nor this, nor this. No, this one is this. It is. It's HSV1, but this one I meant. The scabies mites are where? It's stratum corneum. We finished. Okay. 11th batch, we only have 30 slides left. Which of the following fracture, like someone had a femur fracture of the neck, what will happen to the neck? We said external rotation and shortening. So external rotation and shortening, B. Which of the following is green stick fracture? This is the green stick fracture. It's like when you do this. Which of the following is Galazi fracture? Galazi is fracture of the radius with dislocation of the ulnar, which is this one. Which of the following is buccal fracture? This is a, no, not this one. This is the buccal fracture. It's the fracture that causes يعني just fracture in the bone itself without damage outside. Which of the following are present in the skin? We said Merkel cell are present in the skin. 62-year-old female present with a progressively eroding joint. What's the diagnosis? We can see that there is ankylosing and erosions, so it is rheumatoid arthritis. Which of the following situation is the most urgent? We said cellulitis is the most urgent. So this one. This is erysipelas because or gout. So because it's well defined. So it's not urgent. This one is rheumatoid arthritis, not urgent. This one is cellulitis, urgent. Sexually active 28-year-old female present with septic arthritis. What's most likely causative agent? So we said septic arthritis, most common agent is Staph aureus, except in sexually active people, it's Neisseria gonorrhea. Which of the following is the method in the picture? This is immunofluorescence. So it's immunofluorescence test. We said that immunofluorescence for, if you remember, pemphigus vulgaris and these things. What is this? As you can see here, we which of the following is the يعني, disease? This is osteomyelitis because we have what we call sequestrum, like dead bone and new bone formation and so on. Which of the following is impetigo? We said B. Which of the following route of microbial entry for septic arthritis? Then it's B, the hematogenous spread. Which of the following is seen in this picture? So this is the femur, this is the trochanter, and it's fractured, then it's intertrochanteric fracture. Which of the following is seen here? It's the mushroom budding, so it is osteochondroma. 10th batch. What is included in pilosebaceous unit? We said pilosebaceous unit include three things: hair follicle, pilorectal muscle, and sebaceous gland. Okay, sweat gland are not included. What is the rash of SLE? It's chest and face. We said that. In erythema induratum, which of the following is the site? We said posterior aspect of the leg, so erythema nodosum, anterior aspect. Erythema induratum, then it's posterior aspect. This is Lyme disease. It's due to exodus tick. Which of the following is the germ-line layer? We said stratum basale. Which of the picture is the disease that have a vaccine? And she has slap cheek, and the case should be longer, but this is measles because it has a vaccine. It's the only one that has a vaccine. Nerve injury in shoulder humerus dislocation, axillary nerve. We said that. Which of the following columns shows septic arthritis? So in septic arthritis, if we did synovial fluid analysis, we will see very high neutrophils, inflammation, infection. So it's the fourth column, virulent and very high neutrophils. We said that in the lecture. We said it has leukocytosis and neutrophils. So this one. Which of the following X-ray shows posterior dislocation? It's the light bulb sign. What's this? We said it's seborrheic keratosis, the coin plaque. Which of the following is the function of Merkel cell? We said it's sensation to touch, so it's touch receptor. This is the question that I don't think it will come. Which of the following, يعني someone has inversion and plantar flexion. Which of the following ligaments are damaged? It's A. Just memorize it. I don't think this type of questions يعني, comes in the exam anymore. Which of the following acts as lubricant? So which of the following secretes oil? It's sebaceous gland, so it's G. The sebaceous gland. Act as thermoregulator, sweat gland, and this is the picture of it. Picture of Meriscum contagiosum. I think you should choose the dome-shaped. If it's not there, choose this one. Which dome-shaped is usually the one in the exam. Okay, last batch. So I think last batch, or maybe there's one more, not sure. Erythema marginotum. We said it's erythema marginotum is part of rheumatic fever. It goes due to strep pyrogens. What's this picture? High ferritin. What's this? The tennis racket? That's Langerhans cells. What's this? Also Langerhans cells. Uh, don't think you need to know this. The merocrine secretion of the glands. I don't think you need to know it. This someone has conjunctivitis, keratoderma pelluridica, and arthritis. What does he have? He has reactive arthritis. What is causing reactive arthritis? Either chlamydia or mycobacteria. Uh, so you need to test him for chlamydia immediately because chlamydia is sexually transmitted disease. Okay, so this guy have reactive arthritis. First thing to do, screen him for chlamydia. Uh, which ligament is affected? This is ACL. Okay. Then do we have seborrheic keratosis, blue nevi? This is the chondrosarcoma. Yeah, what's the corresponding scenario? Yeah, what is true about chondrosarcoma? This disease can come secondary to Paget. No, it's chondroblast. So not related to Paget. This disease produce malignant osteoid. No, it's chondroblast. It's cartilage. It is invasive locally without metastasizing. Yeah, that's it. I don't think these types of question comes anymore, by the way. We have a nevi that has hair in it. Congenital nevi. We said that. Someone has osteoporosis. How to diagnose them? DEXA. DEXA is the X-ray for osteoporosis. This is MCQ, by the way. This is not OSPE anymore. Yeah. So, okay, we finished. So we finished solving questions. All right, this is the form for feedback. Please fill it and like give your feedback because I don't know, I'm planning to do more OSPE sessions. I'm not sure if it's for your batch or other batches. If you like this, fill it with like good comments and feedback. If you have any comments, say it. So inshallah in future we fix it. If you have any question, please contact me through my number or email, but I prefer WhatsApp. And thank you.